dangerous. So if you have a very high riding vertebral artery like this, which reaches very close to the superior articular facet, then putting screws here can sometimes be dangerous. So there are two measurements here that you have to remember: the internal height, which is the distance of the vertebral artery cave from the top of the superior facet, and the isthmus height or the pars width, that is the distance of the vertebral artery cave from the dorsal surface of the pars interarticularis. So if you have a vertebral artery cave that is too tall or too high, then you can still pass a transarticular screw like this because there is room behind. But if you have a vertebral artery cave that is too posterior, this will make the isthmus height smaller or the pars width smaller, and in these cases the transarticular screws can be a dangerous screw if there is not adequate room to negotiate the screw through the pars. To identify these anomalies, you need to do multiplanar reconstructions either yourself using softwares like Horos or Osirix, or sit with a radiologist in the department to get these multiplanar cuts which are in line of the screw trajectory. So like this, you can see here you are getting a plane where you are able to pass this screw without interrupting the vertebral artery cave in this first example. But in the second example, you can see that the vertebral artery cave is in the path of your screw before it reaches the lateral mass of C1. So planning is extremely important. So sometimes the vertebral artery notching not only is too high, but it can be too medial as well, like you can see in these pictures. And in these cases, the C2 pedicle screw also can sometimes be dangerous. So that for that also you should be able to do multiplanar reconstructions pre-operatively on CT scan to make sure that you have adequate room in that path of the screw to place it safely without injuring the vertebral artery. And many people think that the PAR screw is a safer screw, but PAR screw is just a short transarticular screw. So PAR screw is a safe screw as long as you stop short of the vertebral artery cave. And if you stop short of the vertebral artery cave and don't reach under the superior facet, that screw is going to be a 14 millimeter or a 12 millimeter screw, which is a very weak and small screw. So that's why more a preferred instrumentation, if your pedicle screw is not possible, is a laminar screw, where invariably the C2 lamina is thick enough to accept a good screw in this particular direction. The course of the vertebral artery is important to understand. We have already seen the V1 segment can have such anomalies such as high riding vertebral artery. The V2 and V3 segment can also have anomalies like this, and there is an enormous variation here, and it's important to recognize this, because if you don't recognize this pre-op on a CT angiogram, you can get into real trouble. So this is an example of a persistent first intersegmental artery where the artery is going underneath the arch of C1. Here you have a fenestrated VA where it is going below as well as above the C1 arch. And here you have an anomalous origin of the pica, where if you injure this artery underneath the C1 arch, you can get a cerebellar infarct or a pica syndrome. In this case example here, the surgeons recognized a persistent first intersegmental artery and have skipped the area completely. But this patient was not so lucky, where they did not do a CT angiogram pre-op. And here you can notice that the foramen transversarium is very rudimentary and there is a deep notching here. This anomaly, if you ever see on an axial cut, you can imagine the vertebral artery is here, and instead of going through the foramen transversarium is actually going inside the C1 ring rather than going through the foramen transversarium. So choose wisely. Some screws are risky with respect to the vertebral artery or anatomy. Some screws are safer, and you have to know pre-operative planning on CT scans, and sometimes we do get 3D printed models to help us make this assessment. So thank you very much. So that was kind of an introductory talk, and I think we will go to the next talk, because these topics which were raised in my talk are going to get repeated again and again. So all of you feel free to ask questions at the end of each talk, because Dr. Bala Murli has a flight to catch. We are going to upgrade him to first class. So he's going to be speaking on occipitocervical fixation. Over to you, Dr. Balamurli, and then we'll take questions for both of us at the end of this talk.
Yeah. Thank you very much for the upgrade, and my sincere thanks to ASSI and Dr. Srivastava for having invited me for this talk. So my talk has become a little bit more easier now that you've already seen the anatomy, because occipital cervical fixation technique is all about understanding the anatomy. And I'll give you some tips and pearls as to how we can go about doing this. So the primary indications are usually an instability, which is either primary or secondary. Secondary is usually due to a decompression at the foramen magnum and C1, and people do develop some problem with kyphosis at this level. But most of the pathology is usually primary, a congenital traumatic infection or inflammatory conditions like rheumatoid arthritis. So the preoperative planning, as it was very beautifully explained, is very, very important to do a CT with an angiogram and an MRI scan. And here it's very important because you want to look at what size of implant you want to use, what is the location of your implant, what is the extent of decompression of the pathology that you're looking at, whether you can put a screw in C1 or skip C1 and go to C2, because you have to connect the occipital to the spine. What is the thickness of the occipital bone, and what is the anomalies as we have seen in the vertebral artery around C1, C2. So it's very important to do a preoperative planning. The next important thing is you're going to fix permanently the cranium to the spine. And so here you also want to see is, how is the patient going to be positioned? So a plain X-ray, a lateral X-ray involving the face and the skull and the spine is very important to know what is the normal posture, because the pathology would actually cause the patient to be in a slightly kyphotic position. And if you are going to fuse the spine in that same position, you're going to run into problems. And neuromonitoring is not always necessary, but certain pathologies you probably need neuromonitoring. So the cervical alignment is very important. We have to look at the correlation between the occiput C2 and C2, C3, the subaxial spine. So if you have an occiput C2 kyphosis, would require a large amount of lordosis as a compensatory alignment. And excessive lordosis at the craniovertebral junction can lead to a reciprocal kyphosis. So understanding this is very important. And sometimes it comes with experience when you see the patient, when you position them in surgery, it's very important. So the technique, what we are going to see is we're going to look at the positioning, we're going to look at the exposure and the implants and all the various connections you're going to make, and a few tips and pearls and how to avoid certain complications. So if you look at the position, it's a prone position, a reverse Trendelenburg position where you want to avoid all the venous drainage, and you have a slightly elevated head. I definitely use Mayfield clamps, and weights and tractions are required in most cases because you want to do some kind of a reduction. And I use it routinely in my patients. Some people do not use it routinely unless they have to do a reduction. So it's very important to position the patient in a similar Concord type of position where you've got a reverse Trendelenburg, your cranium is above the heart, and you also have the weights, as you can see that the weights are positioned, and you give access to your anesthetist in case they want to do anything. And you also have to have the leverage to be able to lift the head or change the position. Once you put the screws, the decompression, sometimes you want to do a slight extension or flexion. But ideally, you want to stand by the side of the patient, look from the side, look at the position, look at the gaze, and take an X-ray and look at all these things. So it's very, very important. And I think in the cadaveric course that we will try and explain this to you, how we do this. The exposure is very important. You do the exposure from the midline, in the midline from the external occipital protuberance down. As it was very beautifully explained, you have to make sure that you don't go above the external occipital protuberance in your instrumentation, because you will hit the transverse sinus. And then lower down, depending on what level and what pathology, you would do a dissection. And this was also explained how you place your pedicle screws. So now once you've done, the way I do this is I first insert the cervical screws. So you can do it the other way around, but it's ideally first to do the cervical screws, whether you use lateral mass, C2 parts or C1, you insert all your cervical screws, because then you will be able to judge about how you want to place, what type of an occipital plate you can use. There are different types of plates which are available, and depending on how your screws are aligned and whether you're able to get this, you can decide on the plate. Whereas if you use the reverse, then you'll be stuck with less options. So the ideal place to put your occipital plate is you look at these lines. the superior nuchal line and the inferior nuchal line would be your safe area. The area 3 is where we marked. It's got the thickest bone, as was very beautifully shown with that light in the skull. It's got the thickest part and the safest part, where you can easily get an anything from a 10 to 12 millimeter screw. So this was again very beautifully explained. I'll skip this slide. When you look at the skull from inside, the midline ridge is very thick rather than the lateral portions. And in adult males, it's anything from about 12 to 15 millimeters, and in women, it's about 10 to 12 millimeters. And as it goes caudally down, you will have it slightly getting thinner and thinner. But it's very important to a CT and look at the CT, because you have so many variations in this. So when you're inserting your occipital screw, you actually go in first at 8 or 10 millimeters. I take usually 8 millimeters. I feel it, I probe it, and then I add another 2 millimeters, and then another 2 millimeters to get a bicortical purchase. Because sometimes it's very easy to just get slipped, and in the worst case, you have an intracranial abnormality, then you don't want to take a chance by inserting your a 10 or a 12 millimeters straight away. So it's better to go step by step. And the fusion rates are much higher with an plate system, plate and screw system than wiring. But I do a lot of pediatric work, and there you do not have systems, and you have to rely on wiring. And in these cases, you have to take extra caution about the fusion, about what you get, a nice fusion mass, a fibular graft or a cranial calvarial graft or whatever you use, but you have to really depend on a lot of fusion. So the types of screws are either occipital plates, or you have a hinged rod which is integrated with the occipital plate, or an various eyelets where you can actually place the plate, and then based on how it comes, after bending the rod, then you can place your screws in a later stage. So that is why I said it's very important to get the cervical screws first, then go to the occipital screws. So these slots are different companies, every company has a different variation, but most of them have this variation where you have midline 3 screws. Sometimes you can get away with even 2 screws, and then you have the slot which can be slightly moved based on how you want to get your rod. So this step is very important to understand before you open the set. You understand what type of an occipital place, and usually every company has a few variations available. So once you have that, as I had explained, you would then start with an awl. Now, with a starter, you make an entry point, and then I use a start with an 8 millimeter. So you have a slot which goes in exactly into this with 8 millimeters. Then you take a drill, and with the drill, then you pass the drill, and you drill it down to 8 millimeters, and then then you use a probe. The probe then allows you to have a depth gauge. You find out what is the depth. If you still can feel that you have not pierced through the inner cortex, then you can go ahead, and then you can add another 2 millimeters now, and go for a bigger one. You have 2 screws. Usually all companies have 2 screws. One is a regular screw, one is a rescue screw. So first you use a normal screw, but in case you have to change, or you're going to remove that screw and place another one for whatever reason, your plate is not sitting well, you're not happy, then go for a rescue screw. Make sure you have a good purchase, because sometimes, if you don't use a proper screw, the purchase is not good, and the whole construct is going to fail. Then once you've done that, then you want to use some kind of an contouring. You want to use this to measure, and they have a template. You can either use a straight rod and you can bend it yourself, or most companies, they come with angled rods of various lengths on the cranial side and in the caudal side. And then once you've done that, you place your plates, and then following that, you place this. And this is a very interesting system which I've not come across, but I've just found this image from the internet, where you can actually slot it very nicely. But it is not very straightforward like this in real use, because it just never usually falls in like that. You have to really contour it, because we're dealing with not normal pathology, we're dealing with a pathological problem. And it's very difficult to get these rods and plates in some cases. It's very important to tighten the entire screw system at the end. So after you've done all of these, make sure that your plate is retightened, and once you fixed all the rods and screws. And this is how it looks at the end of the procedure, where you have the plate and the rod system, and this is a case that we have done. So a few tips and pearls. The screw insertion, if you get a CSF leak, it is okay to get a CSF leak. And sometimes some people say that it is better to get a CSF leak, but you don't have to wait for it. If it gets, just put the screw in. If it doesn't stop, put some bone wax. Usually it's never a problem. Also, the fusion bed, before I insert the rod and before I put the entire system, I prepare the bed. Because once you put the rod, you cannot really prepare it well. So you prepare the bed after you put the occipital screw and the rod. So, and make sure you use a lot of bone graft. Because one of the commonest reasons for failure at OC fusion is where you don't have a good fusion mass. You cannot rely just on the head of the construct. Few other points which were all mentioned: vertebral artery, taking care that your occipital probe does not go inside. You can cause brain injury. I've seen that. I've seen hematomas. Positioning that if your muscle cover is not adequate, you can have an implant dehiscence. You can have it coming outside because the scalp sometimes in elderly is very thin, and it becomes a very big nightmare to deal with this. And in this patient, we actually had to go for a wiring technique and have to have a plastic surgeon do a graft because there was no way we're going to get a plate. And at the same time, if you don't align your head as well, you will end up with a patient with the wrong alignment, not able to see up, or if you're flexing it too up, you cannot see down. So these things are very important. And if you're not somebody done this routinely, please do get help of seniors to learn all these little tips and tricks. So I think with that, I will stop here and thank you so much. And I think more of these things we can learn in the actual cadaver time. Thank you so much.
Thank you, Dr. Bala. Um, that was an excellent talk, very comprehensive. We can take questions for both of us right now. So before we get started, I'd like to ask Dr. Bala a question. So you said about positioning, how it is important so that you don't avoid like too much flexion or too much extension or fixing the patient in an upward gaze or downwards. And the downwards sometimes is really a problem because you can get dysphasias and all. What are your ways of assessing it intra? Like you have positioned the patient. Do you have some like radiographic way that
Yes.
you can measure that angle or just you're eyeballing it? How do you do that?
Yeah. So two ways of doing it. One is once you come to a final position, you want to make sure that your cervical spine is parallel to the ground. That is number one. So I just stay back about a couple of feet away from the patient and make sure that whatever position you put, you put the spine parallel, and then you look at that your gaze, the patient's eye is looking straight down perpendicular. So this is one way of eyeballing it from the side. Second is I take an x-ray again to look at the same thing. I look at how the cervical spine and the cranium is. So these are the two things. I do not use any measures, though they have been described. I don't know how practically useful it is. But whatever it is, I make sure that the patient is not in an extended position, because the extended position is much worse than even if you get a slightly kyphotic position. At least the patient can see down where he's walking. But I've seen patients come with an extended position where it causes a lot of strain of the subaxial spine. So either neutral or slightly flexed is better than having it extended.
Thank you very much. Are there any questions for Dr. Bala before we move? So some people kind of judge the distance between the posterior part of the jaw, mandible, and the cervical spine. Again, I'm not sure how practical that is because the patient's mouth is open because of the endotracheal tube. So sometimes it's like difficult, but I have also found that when you kind of do that chin tuck position, that's not a good position to do occipitocervical because if you get a double chin on the side like that, and then you try to fix somebody in this position, the patient, I mean, I have had one patient getting dysphagia because of that, because you try to fix the patient like in a chin tuck position to make sure that you don't see a double chin, at least like that, when you are fixing these patients in OC fusion. So with that, we'll move on to the next talk. I'll invite Dr. Mihir Bapat. He is on the phone. I have his presentation. Sir, can you switch on your, yeah. So I'll play your presentation. We can't hear you. So Dr. Mihir's talk is on biomechanics of the C1, C2.
The surgical biomechanics of the craniovertebral junction will be discussed under the following four headings: the transverse ligament, the odontoid integrity, the C1, C2 articulation problems, and the vertebral artery anatomy. In an intact C1 ring, the transverse ligament that is attached to the tubercles of the C1 lateral masses holds the odontoid against the anterior arch of the C1. When the lateral masses are fractured and the transverse ligament is disconnected, it creates an unstable atlantoaxial joint. However, in a 3-part or a 4-part Jefferson's fracture, where the lateral masses are intact and the transverse ligament is intact, these patients can be considered stable and can be managed with a soft cervical collar. When the transverse ligament is disconnected, the odontoid tends to shift posteriorly towards the posterior tip of the foramen magnum, resulting in increase in the atlantodense interval, and the odontoid encroaches on the space available for the cord, often creating or mimicking a basilar invagination because the tip moves closer to the posterior edge of the foramen magnum. If the transverse ligament is lax, as in pediatric patients, the atlantodense interval can be stretched up to 7 millimeters. However, this can be considered normal. But these patients are more prone to rotatory subluxations, as is commonly seen in the pediatric age group. The lesions that destroy the craniovertebral junctions, like trauma, tumor, or infections, create more unstable situations because of total disintegration of the craniovertebral junction. In this particular patient, in the supine position, the atlantodense interval was fairly reduced. However, in flexion, there was an instability, resulting in increased atlantodense interval, and a posterior fusion was resorted to. In fractures of the odontoid, particularly the type 2 odontoid fractures, these occur at the base of the transverse ligament, which is also the watershed zone. The fractured fragment and the anterior C1 arch almost always move together in flexion and extension. However, if the transverse ligament is fractured or disconnected, then the fractured fragment can impinge on the space available for the cord, resulting in myelopathy. In this particular patient, the tip of the odontoid was malformed, called as the os odontoideum. The atlantodense interval was increased because of a ligamentous laxity, creating a myelopathy, and this required reduction and posterior stabilization. This particular gentleman had a fall from a height of about 20 feet, a non-union of the odontoid, which was about more than 15 years old. However, the atlantodense interval was reducible and it could be realigned, including a posterior stabilization procedure. The C1 lateral mass, therefore, is a very solid column of bone that offers a very strong purchase for the screws, and it is possible to realign the craniovertebral junction using these strong fixations on the C1 and the C2 pars or pedicle. It is often possible to use C1 reduction screws and actually translate the atlantodense interval into a reduced position using these reduction screws. The contraindications for a lateral mass fixation, obviously, therefore would be a dysmorphism of the C1 lateral mass or a destruction of the C1 lateral mass and an abnormal vertebral artery anatomy that precludes the positioning of the screws. If one C1 lateral mass is destroyed, the other C1 lateral mass is often a very strong purchase, and a unilateral fixation with posterior wiring often suffices in conferring a sufficient stability to your craniovertebral junction. If the C1 spacer is destroyed, then the C2 tends to settle into that space and the dens migrates upwards, creating a basilar invagination in a vertical plane. The cranium then settles into a kyphosis and the dens then progressively gets retroverted, creating more and more impingement on the cervicomedullary junction. And therefore, as the craniovertebral kyphosis increases, the cervicomedullary junction, which is normally about 140 degrees, would become more and more acute. When it reduces more than 110 degrees, it creates a clinical setting for a myelopathy. So the inclination of the C1 over the C2 is the deciding factor and causes a significantly settled craniovertebral junction over the dens. The treatment protocols therefore have changed from a posterior decompression procedure and stabilization procedures or odontoid excisions and posterior stabilization procedures towards the realignment procedures such as the joint jamming technique, the DCER, the anterior release and the posterior reduction techniques. So in the joint jamming technique, the basic principle is to reduce the vertical component of the basilar invagination. The joint is therefore distracted. A spacer is inserted into the C1-C2 joint. The C1-C2 joint is then stabilized using a screw and a plate technique. So this vertical reduction causes a significant improvement in the cervicomedullary angle, though it may not be a perfect reduction, and the reversal of myelopathy was found to be significant by Goel et al. The horizontal component of myelopathy, that is the rotation of kyphosis, is however not sort of provided by this particular technique. In all his cases, Dr. Goel resected the C2 ganglion without any problems, and a meticulous hemostasis is often required to expose the complete morphology of the C1-C2 joint. So in this particular case, a basilar invagination was reduced, the joints were distracted, spacers were introduced in the joint, and a craniovertebral fixation posteriorly was enough to realign the joint using the joint jamming technique. However, there is no clear explanation as to how to put the screws when the C1 joint is almost vertical. The screws therefore tend to cross into the occipitocervical joints and can result in a little bit of neck pain. This was explained by Sarath et al. By introducing the sagittal joint inclination angle. When the joint is less than 100 degrees, it is possible to do the joint jamming technique very easily. Between 100 and 160 degrees or more than 160 degrees, the technique needs to be modified by rotating the cranium back into position and allowing a space for the introduction of the spacer. So if it is less than 160 degrees, you can use this particular thing by using a spacer between the cranium and the upward migration of the pars of the C2 and try to reduce the cranium over the joint, the pseudo joint between the occiput and the C2. And this will give you a rotation of the kyphosis as well as reduction of the vertical basilar invagination. Wong et al. Proposed that if you want to really reduce a kyphosis, then the anteriorly contracted soft tissues have to be released. And therefore, a transoral release or a retropharyngeal release will facilitate the rotation of the cranium by a posterior instrumentation technique. So in this particular case, with a severe basilar invagination, an anterior release was done, and then a posterior instrumentation was used to realign the craniovertebral junction. Now, the vertebral artery anatomy is the most important deciding factor in placement of screws in the craniovertebral junction. And one should always do a vertebral artery angiogram, a CT angiogram, before planning the surgery on the craniovertebral junction. The zone 2 of the vertebral artery between the C1, C2, the zone 3 above the C1 are the two important considerations in the planning. In this particular case, you can see that there are various vertebral artery anatomies that anomalies which can preclude the positioning of the screws. These anomalies are found in about 5% of all cases, and one should be worried to avoid a vertebral artery injury. Particularly in patients with congenital anomalies, occipitalized C1 arch, and 100% variation in vertebral artery anatomy was observed. However, most variation was above the C1 arch, and only about 15 cases were in between the C1 and the C2 joint. So one should be very, very careful in analyzing the course of the vertebral artery. Now, if the vertebral artery is high riding superiorly, naturally, the thickness of your pars, which would adequately take a 3.5 or a 4 mm screw, that funnel is reduced, and therefore a short screw would be preferred. So use of navigations usually is useful in circumventing a few of these anatomical variations. However, because the anatomy is difficult, one still has to be very careful in trying to maneuver a screw around the vertebral artery. So if you have a medially encroaching vertebral artery, again, one has to be very careful in introducing a screw, and you can use an additional fixation on the C3 if the C2 part screw is extremely short. C2 laminar screws are also used as salvage screws, but you require special connectors because they fall out of line from your C1 and the C3 screws. So you can put your C2 laminar screws and get an extremely good purchase on your C2 thick lamina. Now, this 11-year-old child presented with multiple strokes, convulsions, and you could see multiple infarcts because of an unstable atlantoaxial joint and vertebral artery anomalies. There were various tributaries which were crossing the C1, C2 joint, and therefore a separate C1, C2 fixation could not be used in these particular cases. The occipitalized C1 arch allowed us to use the cranium, reduce the C1, C2 joint, and fix the occipitocervical joint in a realigned position. In this particular patient of ankylosing spondylitis with a very, very restricted mouth opening and obese guy, there was an atlantoaxial dislocation. Now, the biomechanical considerations were not paid attention to. An occipitocervical fixation was done in an unreduced position, which fell off in 6 months. The kyphosis increased as they had done a posterior arch excision and a foramen magnum widening. So the basilar invagination increased and the cranium settled into a kyphosis. The anatomy of the C2 parts was extremely dysplastic. The vertebral artery was high riding, and therefore there was a very narrow zone which was available for the use of maneuvering the C1 arch over the C2. A C1 C2 osteotomy was done, and a posterior joint jamming technique was used to distract the C1 C2 joint to whatever best possible extent it was possible. The odentoid tip was moved into a favorable position, and a very rigid fixation of the cranium to the upper cervical spine was used with a good result. In difficult anatomy, a 3D reconstructed model is often used to plan the fixation points to study the anatomy of the vertebral artery and to avoid catastrophes intraoperatively. Thank you.
It is you have
Thank you.
on-
Thank you, Dr. Mihir. Those were very difficult cases. Can you hear us, Dr. Mihir?
Yes,
So
I can hear you.
if there are any questions, delegates, you can put them in chat and I can ask Dr. Mihir. I'll ask two questions. One is, what according to you is the difference in the biomechanical strength of these different constructs, like say transarticular screw, C1, C2 harms technique versus using laminar screws and par screws. Like, what is your preference in terms of the choice given to you, considering that, all types of screws are possible in a person?
Kshitij, can you hear me?
Yeah,
Can
we
you hear
can
me?
hear you.
Yeah.
Yeah.
So I think the choice is between Harm's kind of a fixation, C1, C2 lateral mass versus a transarticular screw. That is the debate in most of the cases. So really speaking, the fusion rates, if you see in both the cases, are almost equal, and really doesn't make a difference whether you use a transarticular screw or a C1, C2 lateral mass. Transarticular screw is a technically demanding procedure, and it needs to be learned quite correctly. C1, C2 lateral mass is also demanding, but at the same time, it's a relatively easier procedure to do if you know the anatomy. And that is why the whole trend is sort of shifting towards a C1, C2 lateral mass fixation, because it offers you sort of a better control over the C1, C2 lateral masses.
So basically, you're trying to say both are equal, but the anatomical constraints and the technique determine which choice you make.
Yes. In the C1, C2 junction, yes.
So the second question I have, I don't see any questions till then. I have another question, which is related to how the load gets transferred from the skull to the cervical spine. We know that in the thoracolumbar area, you have the anterior column and the posterior column. But how does the biomechanics change at the craniovertebral area in terms of weight transmission? Let's say you have, like, say, tuberculosis where your odontoid is destroyed. Would you want to reconstruct it with a cage or something? How does the biomechanics in terms of load transmission changes?
Yeah, so I think odontoid is just a sort of a peg which controls the C1, C2 rotations. Apart from that, the main weight-bearing pillars are always the lateral masses. So you have the load shifting from the occipital condyles into the C1, C2 lateral masses and going downwards. So if you have really erosions or fractures of the odontoid, all you have got to do is stabilize the lateral masses, and in most cases, most of these problems would come under control. So it is always the C1, C2 joint, as Dr. Goel says in most of his presentations.
Thank you, Dr. Mihir.
And
Sir,
moreover, I will add, actually in CVJ area, the load transmission, it is a Y-shaped beam. So the load transmission is from the skull to the condyle to the lateral mass, and then it converges to the C2 body lower down. So it is a Y-shaped beam. That's why the peg that is dense doesn't have much of the weight bearing thing. It is for basically for the rotation. It has a participation, and it gives stability in sagittal plane.
so that's a very important point which Dr. Mihir and Dr. SKS make, is that the reconstruction is directed towards the facet joints, and this is kind of a recurring theme that you will see in the next 2 or 3 hours. So we'll move on to the next talk, which is by our president-elect, Dr. Shrivastava, and he's going to tell us about algorithmic approach to the management of craniovertebral disorder. So
Yeah,
you can share your screen.
Yeah, I will share. This, can you disclose this chat box, please? Yeah. So I'm going to talk on algorithmic approach to management of CVJ disorder. It is not moving. So what should be an approach to a CVJ case? Beware about the CVJ unique anatomy and biomechanics. There may be different etiology. You have to identify them. You must do the thorough clinical assessment and do essential investigations. Now, regarding this treatment, everything has not to be operated. It should be specific pathology directed, like in a case of tubercular AAD. So medication is important thing. You optimize the patient, and all these syndromic patients also, they have a lot of compromise on their respiratory and cardiac reserve. So in that case, that is to be improved. Nutrition has to be improved, and then comes the local treatment. Local treatment, basically you want to align the column, and this malalignment may be in different planes. It may be in sagittal plane in form of subluxation or dislocation. It may be rotatory subluxation. It may be in vertical plane, that is basilar invagination. No, so we will just discuss that CVJ a unique anatomy. It is a Y-shaped beam where the C1 works as a small bushing. We also discuss about the congenital anomaly in the vertebral artery. The incidence is almost 5% unilateral and 11% bilateral. These structures can fail if there is a pathology. Even if you operate, there may be alignment failure. There may be further neural compression and there may be deterioration. Now, see on the left side, this fixation was done, but you can see it has failed. It has come out because it has not united. In another right side, the case which has been uploaded here, though the fixation has been done, but the clivus canal angle is significantly reduced. So that should not be the proper alignment, and some of these patients, they might deteriorate and might not improve. So most of the time, proper alignment leads to neural decompression. Meticulous fusion in biomechanically aligned column gives a long-lasting, fruitful outcome. These patients usually present with the pain, neurological deficit, or deformity. There may be mechanical compression. It may be osseous compression because of the anomalous bony mass. There will be neural compression because of the tonsillar radiation, syringobulbia, or milia. Instability is the main cause of deficit, because we know this area is capacious. So instability usually leads to deficit, and we can have congenital AAD. Tuberculosis common in our country, and that might represent with the neurological deficit. There are changes in the vascular and CSF dynamic in these cases, and one should be able to identify what is the cause of signs and symptoms on that particular patient. There may be various pathologies. It may be grouped into two, congenital or acquired. The congenital, it may be associated other congenital anomalies. So there may be osseous, neural, vascular, and there may be connective tissue disorder. There may be missing bone, there may be abnormal assimilation, and there may be neural compression because of these. In acquired pathology, we can have tuberculosis or pyogenic infection, tumor cases, inflammatory cases. The rheumatoid is common and it can lead to instability. Trauma to this area can also lead to instability, and sometimes they're non-union. And degenerative arthritis, actually, this has been actually now picked up very well, and now people have been picked up because of having degenerative arthritis in OC1 or C1C2 area. And earlier they used to just complain of pain, and people never paid any attention to that. Usually the people who are actually lifting heavy weight on their skull. So this also should be picked up. So the neural compression and instability is the main problem in CVJ pathology. The issues of implant purchase is always going to be there, and one should learn it properly. And poor bone is there for the fusion. There is a lot of mobility, so one has to do the meticulous fusion procedure there. It is important to identify the cause, pathogenesis, and resultant effect. Now, these patients, they can have high cranial nerve involvement. There may be difficulty in deglutition, swallowing. There may be numbness. They might be coming with a little bit of the vision problem. There may be poor balance, difficulty in walking, tightness in the limb. And we should be able to know these things, whether it is related to our proximal or high compression. The signs are usually, there may be changes in the facial feature in this congenital and syndromic child. There may be low hairline associated with the visible limb anomaly. Other features of syndrome may be there. There may be a change in the functional finding in the higher cranial nerve involvement. There may be wasting of the muscles. There may be altered reflexes. In a quiet condition, there will be spasm, it may be painful, it may be tender, and all these patients might have upper motor neuron signs. Now, beware of the late presentation. We know there is a Steele's rule of thirds. That tells that there is a significant space there. So usually patients present late, and we should not miss the stigmata of finding of congenital anomaly like this. There may be low hairline, and there may be some deformity in the cervical area. There may be mild torticollis, and we should be able to suspect that this patient is having CVJ pathology. Now, investigation, we should always do the plain X-ray, and in this, open mouth view is important, where you see the alignment of C1 and C2. Here in this case, you can see there is a widened distance between the dense and the lateral mass. You always ask for dynamic view, where you can see whether it is getting reduced or not. So in this case, you can see it is getting nicely aligned. So it is a reducible AAD. Even after surgery, you want to check, and you should check with this whether in dynamic view it is stable or not. And it is an important baseline investigation. MRI is going to tell you about the site and extent of the neural compression. You must try to know what is the cervicomedullary angle in that specific case. Normal, it is 135 to 175. It is reduced when there is a compression or when there is a malalignment. You must assess the vertebral artery. So always try to see the axial cut of the cervical spine. And those small foramen gives you an idea about the status of the vertebral artery. The CT is an important tool where you can see the osseous anomaly. You can also have an idea about the anchor points. And in post-operative cases, you can get an idea about the healing of the fusion mass. So these are the three important radiological parameters. You must pay attention to the clivus canal angle, cervicomedullary angle, and how is the lower down or subaxial cervical lordosis. This patient, he has a normal clivus canal angle, but you see there is a reduced, cervicomedullary angle. Here you can see, because there was a soft tissue compression. Now, what should be the treatment algorithm? So any case of AAD, we first try to position it and give traction. And there may be two things now. It is either reduced or not reduced. If it is reduced, we say it is reducible AAD. If not, then we say we label it as an irreducible AAD. Now, in reducible AAD, if it is stable, you go for Philadelphia collar and put the patient either on collar or halo brace or corset. And many times it might, become stable, and follow-up thing you find it is remaining stable. But if it is unstable, you go for posterior fixation and fusion. You can do either C1, C2 fixation or occipital cervical fixation in that specific case. Now, this irreducible AAD, once you try to release it, as we do in peripheral joint, if there is delayed, a case which has come to you, you want to reduce it, it is stiff, you release, and then you try to reduce the joint. Similarly, we can do this here also. You can release the tight soft tissue and you can get a good alignment. Now, this release can be done anterior, where you can release through the extrapharyngeal approach or transoral approach. Then you will be able to reduce it, then turn the patient prone, and you can do posterior fixation and fusion. Many times now people have started doing from the posterior side. So you do the release from posterior, where you release the joint and you can burr even the anomalous bone and then go for posterior fixation and fusion. You must be aware also about the previously thought process which the older surgeon used to do. They used to think that this is irreducible AAD, and then they used to go and do the transoral odontoid excision. Or sometimes they started doing posterior fixation and decompression. They started doing the foramen magnum widening and posterior arch excision of C1. And at second stage, they used to think whether there is an improvement or not. If there was no improvement, then you used to think of doing the second stage odontoid excision. But nowadays, with this release, everything is getting aligned nicely, and we are able to do it very effectively. Now, this can treated with conservative treatment, like tuberculosis is the commonest example. You can see there is AAD in this young girl, and with the initial traction, it has fallen into place very well. And then later on, she was treated with the brace. And you can see the late follow-up X-ray dynamic view, it is absolutely stable, and this got healed very nicely. Now, this is another case where there was AAD because of tuberculosis, a very unstable case, and here occipital cervical fixation and fusion has been done. You can see practically everything. There is a pus, C1 is significantly destroyed. So in such situation, you cannot have any purchase on C1, sometimes even not in C2 also. So in that case, you have to go from occiput to lower down. Now, in this case, we have purchase over the C2 and occiput to lower down till C3, fixation and fusion has been done. You can see here the graft had been shaped nicely and it has been fused nicely so that it can have a long-lasting result. Now here, if you see this case, there is a significant reduced cervicomedullary angle. There is a soft tissue material which is causing compression. So here, when we opened this case, there was significant amount of pus granulation tissue that we took out, and then this was this procedure of occipito-cervical fixation with the hard-sealed rectangle and subluminal wire was passed, and you can see copious amount of graft has been put here. So this step is important. You should meticulously fuse these patients. If there is a reducible AAD, you can do the transarticular fixation. Now here in this case, apart from transarticular screw fixation, I have also added galleys fixation. So this construct is very strong, and graft is also stabilized in that position. If it is partially reducible, then you can pass C1, C2 separate screw, and then you fuse this area. Now here you can see I had used the reduction screw. It has been nicely aligned and it has been fused. In irreducible AD, now this case, when it came to me, he was having only one finger breadth of opening of the mouth. So here extrapharyngeal release was done, and always because it is slightly tangential approach unless you take very high incision and try to protect the soft tissue. You can see here specifically I have bent the tip of the quadri, insulate this whole quadri length, and then try to release. You have to just cut all the tight soft tissue structure and you will be able to reduce it nicely. Now here you can see my periosteum is there between C1 and C2, and this has reached in this area. It has been realigned nicely and it has been fixed and fused. You can see there is a significant improvement in the alignment, and this patient improved neurologically. So I will conclude, craniovertebral anomalies can be treated efficiently. Address the etiology, try to achieve the normal CCA and CMA, meticulous neural decompression and fusion in biomechanically aligned position usually gives a long-lasting, fruitful result. I thank you very much for your kind attention. Yeah, Kshitij. You have unmuted yourself. Kshitij, you are not audible.
Hello, can you hear me now?
Yeah, you can hear it. Yes.
Yeah, so thank you very much. I would like to welcome our invited guest faculty, Dr. Abumi. He is also joined.
Good.
Hello, sir.
Yeah, Dr. Abumi. He's not.
So, I'll ask one question to Dr. Shrivastava about, how you make a decision. I always struggle between making a choice when somebody requires an anterior release. You have a patient who is, say, maybe not fully reducible, somewhere in between, has a very high joint inclination. How do you make an object? Do you have kind of an objective way of assessing whether, okay, I can do the DCER or a posterior joint distraction technique and get away without doing an anterior release?
Yeah. So here, basically, this anterior procedure is actually, I would say, very small procedure. They have to release the thing. Even if you have to do something from behind, it is better to release the tight soft tissue structure anteriorly. So even if there is a mal-aligned joint, I will be going for anterior release. From anterior side also, you can burr that area. Okay, many a time, if you see in the CT, there is a abnormal bend, that Dr. Mihir had shown one of the, like a dents which was deformed. And you see even if you release and you try to bring it, that bony part will be coming in your way. In that case, you can in fact burr that bony part from front also. Now, only this regarding the issue of joint alignment. If it is a vertical joint, how we are going to do that? Try to release from anteriorly all soft tissue and then add further release from the posterior side. There, once you align it, means if you have created the clivus canal angle nicely, even in that joint, oblique joint, if you partly fuse it also, this is going to work out nicely. Once you have created the alignment, then there is nothing problem. There will not be. So only I will say only three things in CBJ. One is the clivus canal angle. another is the cervicomedullary angle, and third is your sound strong future, and this will survive.
So it just means that you would rather do an anterior release if you have a doubt. Is that what you are trying to say?
Yes.
So, Dr. Sharat Chandra, do you have another take on this question that I asked? Like, would you always try to do everything posterior with the joint manipulation or add something from the front? Dr. Sarat, can you hear? Or maybe Dr. Abumi can take that question if he can. Dr. Abumi, can you hear?
You have to unmute.
Question, the hot question again.
So basically the issue of irreducibility, I know that you use very powerful instrumentation from the back to correct dislocations, even if they are not moving that much. So what do you rely on the most, your implants and traction or some kind of a release in the joints?
We can get some motion by the traction or extensional force. Maybe most of the case we can reduce. But if patient had bony union, the anterior, maybe we need anterior release. But I don't have many cases, or very small case. So most of the case I can do only from posterior.
Only from posterior. And would you say the success of your posterior corrections is dependent on, like, I know that you put cervical pedicle screws also like in the C3 and all to get a better purchase to reduce. How much importance would you give to that kind of fixation? Because you can generate a lot more forces that way.
He has to unmute. Dr. Abdul, you have to unmute.
Okay.
Yeah.
Both of the occipital bone and also the cervical spine. If we need, we can increase the fixation number down to C2, not only C2, C3, C4 like that. Most of the case we can reduce, but if patient has a completely bony union of the anterior, maybe we need anterior decompression or anterior release firstly.
Okay. Thank you, Doctor.
Can I answer your question?
So, yeah. Can you, what is your take on it, Dr. Rudrappa? I would like to know what you think about it.
See, considering the Atlantic axial dislocation, there is no word called irreducibility. There is some way we can always reduce it. The posterior procedures have a greater strength as of today compared to what we used to do anteriorly. So, for example, the case Professor Shrivastava showed, I would have done 3 ways of doing it. One, during the position after the anesthesia and the muscle relaxant, use the Gardner-Wells traction or the Sugita frame or a Mayfield. Pull traction, give much more traction under the IONM or watching the pulse and extend the neck. It releases to a certain extent. Second, when you go inside, once you release the muscle, you attempt the same pulling once again. Third, when you open the joint, take out the cartilage and put the spacer with a long arm. Spacer means, when to measure the spacer, you have the long arm ones, which like a Wang technique, you can pull and open the joint completely. Keeping the spacers in, you can distract some more and extend the neck. Even with that, if it's not happening, then you can use the DCR technique. And with the use of these methods, the anterior procedure is most often not required because it is time consuming. At the same time, you're doing the single procedure as a double procedure. And as Professor Abumi said, unless there is an anterior calcification or fusion of the C1, C2 joint calcifications, which happens sometime, during that time, it will not distract. It's the only condition where you have to, open anteriorly.
Thank you very much. There's a very interesting take, different takes on the same pathology. But the principle remains the same, that you want to align it to the best possible way in correcting the kyphosis and the cervicomedullary angle. There is one question from the delegate about traction to determine reducibility.
what is your like sequence of doing it, Dr. Shrivastava? Are you doing it over days, hours?
No.
How do you decide the weight?
Yeah, so actually this is over days. It is not in hours as we do in traumatic, subluxation or dislocation. So here you put the patient on traction, and you see the alignment of C1, C2 region. And initially you also try to judge how is the angle of your dents. If there is a basilar invagination, you will try to pull it straight and then try to keep in extension. Now, though it becomes a tedious job, but it is close observation is extremely important, because you have to monitor the patient. In that case, apart from the neurological examination, you should also see the occiput. And usually in KM hospital, we used to keep the patients on the foam, so that there is no occipital sore, because you increase the weight. So initially we used to start in such cases, a very stiff cases, you start with the 5 kg, and then you gradually increase over the time. And you see if there is associated basilar invasion, it starts coming down. And so this, you are correcting the vertical displacement. And for the sagittal correction, you try to extend the neck further, so that you are able to align in the sagittal plane. In that case, you can also take the help of putting a pillow beneath the shoulder of the patient, shoulder and the lower part of the cervical spine, and then try to extend the neck. Sometimes if it is too tedious for the patient, in that case you can discontinue and go for the release state. But even if you have planned release or anything, it is always better to stretch these soft tissue. So traction is going to have a definite role in these pathology, where when you are stretching it gradually in the ward, there is a time taken for this gradual elongation of this soft tissue, or there may be some release because of this traction also, the softer one, not the very rigid one. But there is a role of traction. See what happens in surgery. During surgery, when we do acutely, we release this thing. We don't know what is going to happen to the vessels. Okay, we don't know what is going to happen to the neural structure. Though we are going to use the neuromonitor, but it is always advisable to put the patient on traction initially.
So thank you, Dr. Shrivastava, about the traction. And from traction, we'll move on to the next stop. You have Shrijit.
Yes, sir. So,
Go ahead.
So good presentations by the teachers. So I have a query. So when we put up a spacer to distract the joint, so if we see in the hindsight, we are also distracting the vertebral artery. So how to determine the size of the spacer? Like preoperatively, we get to know, or we put as a, based on some calculations, we put the spacer size, because we have to keep in mind that we are stretching the vertebral artery also, and most of the time they are anomalous. So how to correlate? Because there are incidences of vertebral artery injuries when you put up a spacer to distract the joint. So what is the consensus on that, sir? I would like to ask the teachers.
So I'll put that question to Dr. Rudrappa. Sir.
See, strictly speaking, normally the course which vertebral artery takes, vertebral artery is not anomalous here. See, it's a misnomer, anomalous. It is a abnormal course it takes because of the bony and soft tissue pathology. So strictly speaking, if you see embryologically, the mesenchymal cells of the vessels forms earlier than the mesenchymal tissues of the soft tissue and the bony components. So if you see any origin of any organism, the blood vessels are usually will have a course, and it takes abnormal course because the bone anomaly creates a secondary angulation here. So spacer length does not matter for the stretching of the vertebral arteries. Rarely ever. I have done significant amount of the CVJ. I have never had any problem related to vertebral artery, and nowadays I use the Doppler in every patient of every variety of the angulation of the CVJ. And I have now spacer up to 7 and 8 mm is also available. Till recently only 6 mm was available. Even up to 7 mm when I put, there is absolutely no change of pattern of the vertebral artery involvement. So you don't have to worry because it has elasticity. Second, because the course of itself will allow it to expand up to 1 to 1.5 centimeter without any problem.
Can I add one more point?
Yeah.
Now here,
Yes.
if you see the course of vertebral artery, they make loop. So they have significant amount of laxity also.
Correct.
When it is during its course. So I think this problem one is not going to face. If disaster has to happen, it can happen anyway. But I think this is not going to happen. Putting the spacer and vertebral, unless you put the spacer very near to the vertebral artery and you are almost impinging, that might be the separate issue altogether.
So
Okay, sir.
thank you very
Okay.
much. For want of time, we'll move on to the next talk by Dr. Agnivesh Tikku, who is going to tell us about traction and how to put the various tongs and mayfields and halos with which we give traction and positioning. So over to you, Dr. Agnivesh. You can share your screen.
Yeah, can you hear me?
Yeah, we can hear you.
Okay. Thank you, Kshitij sir, Shrivastava sir, Mihir sir, and Satish sir for giving me this opportunity. In the interest of time, I will be restricting my talk only to the application of the cervical traction apparatus. Is my screen visible?
Yes.
Okay. So we all have different set of instruments available for cervical skeletal traction, or what we call as skull traction. We know that the basis of all this was the old Crutchfield tong, which was used by W.G. Crutchfield. There are some reports that a neurosurgeon, Hepburn, used it in Edmonton in 1920s. What he did was the ice tongs. He made a modification of ice tongs that he used to put in skull. And since there was no ratchet mechanism to lock it, he used to use the inner tube of the cycle tire to closely tighten it. And with that, he gave traction. And this experience was based on the victims of World War I. Even in Crutchfield's report, it is at one point referred to as Edmonton extension tongs. But the main credit is by the W.G. Crutchfield, who developed these tongs. These tongs evolved over next few years to get to the current situation where we use this. It's now a elongated tong, and under local anesthesia, pin sites are selected. Usually this point is in line with mastoid because this corresponds to the facet joint, and you can directly give traction to this area. 2 points are selected, 11 centimeter from vertex. They should be around 2 to 3 centimeters above the pinna and below the equator of skull. The outer table is drilled with a guarded drill bit. So in adults, it was 4 mm, and in children, it was a 3 mm drill bit which used to come. And we had to give local anesthesia, make a stab incision, and then we would drill the outer table with this drill, and we would then place the Crutchfield tong in place. The modification or the next generation of Crutchfield was Gardner-Wells tongs, where you did not need to do this exercise of drilling because they had self-drilling pins, and it was a self-loading pin wherein the pin would show you the correct amount of force applied, and you did not do that exercise of drilling the skull and sort of putting in the tongs. You could directly apply these tongs. Now, there are reports that with these tongs, you can apply up to 140 pounds of weight. But if we are referring it to CVJ junction, it may be much less than that. And usual limit for a cervical was also 1/3 of the body weight. And eventually, you would place this set of tongs over a horseshoe or a similar apparatus, and you have this pulley where your traction rope would go, and you could suspend the weights from there. We are now using more of Mayfield or Doro clamps. They are respective trademarks of their respective companies, and they have slight difference in alignments and all of that. But more or less, they work on the point of 3-point fixation. There are a lot of modifications of these clamps which are used for skull surgeries, but for cervical, this 3-point fixation is good. I have prepared a small video of how do we apply these tongs. So once the points are selected, we apply a tinge of betadine around it and we place mucinase ointment on the tip of the tongs. We have to avoid the temporal area because that is thin bone, and the tongs should be freely, this clamp should be freely mobile over the face. It should not be impinging on the nose or forehead or anywhere. Once you have put this in place, you need to tighten the screws. So this shows you about what amount of tension you are giving on the screws or weight you are applying, pressure you are applying to the screws. Usually the maximum is around 80 pounds. In osteoporotic bones, we tend to keep it less to around 60. So the markers on these pins, which you can see here, show you the amount of force which you are applied. And once you have positioned the patient, this is how the patient is positioned. The head is stable. You lock the body and you ensure that you have adequate tension on the spring-loaded pin even after the positioning also. And then once you turn the patient, one has to hold the Mayfield clamp. Many people prefer to use the clamp here only and hold the face, but I prefer holding it. Your assistant will remove the locking pin. It has to be, there are 3 locking places and you have to remove them one after other. And then you will log roll the patient. It's preferable that the surgeon keeps on holding the head of the patient because he's in charge and he's in command. And slowly you turn the patient, taking care of all the wires, tubes, and all. And once you have turned the patient, you again unlock the rotational lock of this clamp, which is here. So this is the rotational lock. So you remove it and then the clamp becomes free again. And then there is a pin which you pull and it unlocks the ratchet mechanism and you can remove the pins and you apply some antibiotic ointment on the pinholes. Halo is a much versatile where you get much more liberty of choosing your pins. The advantage is that this can be converted into a halo vest. It can be applied preoperatively as a part of a halo gravity or a halo traction. And intraoperatively, you can continue doing your surgery in the same frame. And you can then post-op convert it to halo. So this is the halo, which is made of a carbon fiber. We have Indian ones also, which are made of steel. They usually are as a complete ring because this you have to get more thickness to let it be that strong where it does not distract. So this is how you place the halo on forehead. Your pin sides have to be above elbows and you target the lateral third area of the eyebrow because that is where your frontal sinus is not there. Your frontal sinus is medial and you have these epitrochlear nerves which are going from the inner 1/3 of the orbit going cranially. So once you have done that, so there are temporary pins over in this frame, which you can see here. So these are the temporary pins. So you put these pins through here and this frame then gets locked onto the skull and your hands are free. You don't need any other thing to hold the frame thereafter. Before positioning, you have to have something below the neck, even like a good saline bottle, so your head is suspended, or you can use a head ring also if your case allows. So this is how the pins would lock the frame onto the skull. Using a light torch, you mark the insertion points, which you have already decided on the preoperative CT. And in adults, we use 4 points. In children, because their skull is weaker, you have to use more pins. So you may use 6 to 8 pins there. And through the same hole, you give the local anesthesia on the pin spots where it is you are going to insert the pins. Then you need to make a stab incision at the same place. So this is the torque wrench driver which comes. This is prefixed for adults to 8 inches. There is a screw behind it. You can loosen this screw and this torque would reduce. So this is because these pins of this particular halo are sort of sort of tightening and they are to be torqued. They are not very sharp pins which would go into the skull like other systems. So they get locked at a particular torque. So once you have placed the pins, you have to put them diagonally. In a normal halo, you would like to place them at around 2 o'clock, 8 o'clock, and then 10 o'clock and 4 o'clock and tighten them diagonally, like 2 o'clock and 8 o'clock will be tightened together. And then once you have tightened the pin, you put this stopper or the lock over there. In some halos, it is recommended that you tighten the pins and inspect regularly. But in this or most of the newer systems, you just tighten it on day one, just see if it has become loose or anywhere, and then you do not tighten them at all. And once you have placed these pins on the skull, you cover them with the protective caps. So this doesn't interfere. You remove these temporary stoppers which are there, and you apply this cranial traction apparatus, lock it with the screws, and then you can use a S pin with a suspended traction weight to control it. So this is a child whom we had operated. So this halo was put preoperatively as a part of traction, and then we did the anterior release and then continued traction and then posterior surgery in a second sitting. Thank you very much.
Thank you very much, Dr. Agnivesh. Excellent talk with very good video demonstration of different ways in which we get traction. I would like to, before we take questions for Dr. Agnivesh, I'd like to invite our organizing secretary, Dr. Vishal Kundani, who is here to welcome all of you, all the delegates for this course. So over to you, Vishal. He's also the faculty after some time, but he can join in here.
Kshitij, thank you so much. I take this opportunity very quickly to welcome all the lovely faculty members from across the country and abroad to come and join us for this and make this a possible session today, which is the part 1 of the cadaveric session. And I take this opportunity to also welcome all the delegates, and I really wish you all have a wishful learning. Special welcome to Professor Abumi, who despite his health has taken out time and spare time on this odd hours also to join us. Dr. Satish Rudrappa from Bangalore. Welcome on behalf of ASICON 2024. Mind you, delegates, this is not the only cervical or craniovertebral junction learning during the conference, these few hours, plus during the cadaveric workshop that you will see on the 21st in Somaya Hospital. There are so much that has gone in before this session also through the global sessions, which will be available very soon online to view. The recorded version of this is also going to be sent back to you through the links. But during the conference ASICON, there are 7 long hours of craniovertebral junction learning, more than what you are learning today. There are hands-on workshop on various instrumentation techniques of CV junction. There are sessions on CV junction. There are sessions on AAI, and there is a lot of microscopic technique workshop that is going to be helpful in cervical surgeries to develop your skills. So with this, without much ado, I take this opportunity to welcome you all again to the Maximum City of Mumbai and the Maximum Conference of ASICON 2024. Welcome, guys, and cheers.
Good, Vishal. Best of luck, and you're doing a great job.
So thank you, Vishal. So let's take questions for Dr. Agnivesh in the meantime. If there are any questions, you can ask in chat or raise your hand here. It's kind of a basic thing to do, tractions, but if you don't do that well, you can land up in serious problems during surgery. So one question for you, Dr. Agnivesh, in which cases of craniovertebral problems would you prefer a Gardner-Wells traction over a Mayfield tongs, or would your choice always be Mayfield tongs because the face is free and all that advantages that come with it?
So if the traction is required only intraoperatively and the Mayfield is not available, then in that case, I would prefer a Gardner-Wells tong. Otherwise, mostly in all cases, I nowadays end up using the Mayfield only because it's more controlled. Intraoperatively, you can change the direction of the traction. You can do slight reduction maneuver if you have to do. It's much more controlled than a Gardner-Wells tong. If Mayfield is not available, then only my this thing would be for a Gardner-Wells tong. Second is that these Gardner-Wells tongs, they are not very comfortable for preoperative inward traction, because nowadays most of the Gardner-Wells tong, you get their pins are slightly inclined backwards, and that sort of creates a problem if the tongue you have to slightly move, it creates a scraping effect onto the skull and it causes a lot of pain. As compared to the older Crutchfield tongs, which we used in my PG days, their pins were vertical and 90 degrees. So you could virtually sort of move the tongue as you would move a Mayfield clamp, and that would sort of avoid that preoperative pain. So to sort of make it concise, if I do not have a Mayfield, then I would prefer a Gardner-Wells tong only, because it's much more safer. You have 3-point fixation rather than a 2-point fixation of a Gardner-Well. Rotation can be better controlled. But if you don't have a Mayfield, then my option will only be a Gardner-Well.
So just a quick, you said about traction and the amount of traction that we can give. You said 1/3 of the body weight of the patient. So let me quickly ask the faculty who is there, Dr. Shrivastava, Dr. Satish, Dr. Abhumi, Dr. Sachin is also here with us, Dr. Amit. What is your take on the maximum amount of traction that you would be able to give? Would that change? Would that depend only on the body weight, or would it matter? Would a pathology matter, where certain pathologies you are very careful versus some you would kind of go to extreme lengths to put the weight on? Dr. Satish first.
So, Dr. Kshitij, sorry, I just want to correct. I said that in craniovertebral junction, you will probably not be using that much high weight. So it would depend upon the level also.
So just we are expanding the topic of how much weight is weight. Right. About 1/3 ballpark is what I would also use in most situations. But just to make it a little bit more granular, Dr. Satish, what is your take on how much traction can the craniovertebral junction tolerate?
So, as you clearly mentioned, it depends on whether we are using it for congenital pathology, or is it a trauma or an infection. Obviously, trauma and infection requires a lesser weight, because there will be pathology already and the reduction becomes much more easier. Whereas in a congenital, it requires a larger amount of the traction. Normally, from the basic, from our student time, I studied at NIMHANS, where we used to put the patient on traction for months together, thinking that it'll reduce. But however, in the present day, we use about, per vertebrae, it is about 2 kgs per vertebrae in the cervical region, and maximum we go to 17 kgs. And we will wait only for about 24 hours to see any visible change in the radiology. And if there is no change in the radiology nor any clinical improvement, we usually discontinue, because further usually it will not improve at all. So, on an average, if you take 2 kg for the occiput, 2 for the C1, 2 kg for cervicals and C2, normally we start with 6 to 8 kg, go maximum to about 17 kgs I mean to say up to 18 to 20 years old people. And in adult, we can go another up to 24 kgs for 24 hours. If there is no change, we discontinue it, because there's such a discomfort to the patient, as well as for unnecessary anticipation in supine position.
So, Dr. Abhumi, what is your take on this, on congenital anomalies of the craniovertebral junction, amount of traction that you can give, the weight of the traction? How do you decide that?
I usually use the Mayfield tongue. Mayfield is much better than Gardner, old type of Gardner, because it's a more controllable direction with the traction. So much easier to control the direction of the traction. And I don't remember how much I applied the traction force. Usually up to 20 kilograms, like that. Maybe. I thought it depends in the case of the trauma, but usually not so much. Maybe
so
20.
On Mayfield, how do you judge the weight?
It depends on the pathology. In the case of pathology and age and osteoporotic stage, like that. So I cannot say correctly. So maybe we have to consider many factors.
Thank you, Dr. Abhumi.
Yeah, Kshitij. Actually, this is an important question which you have asked, and there may be varied answer to this. what has been already discussed, it depends upon the pathology. And this traction is actually, this should remain with us. It should not be discarded. It is not only the skull traction, or skeletal traction. Sometimes we use surface traction also, like Sayers traction. If you see the patient has a spasm, significant tenderness in TB spine, in that case, we just put Sayers traction and patient gets relief. And even there is an improvement of the alignment, because you are not going to, have a significant weight in those patients. So surface traction plus skeletal traction. Skeletal traction, according to the pathology, you have to decide. Like, it has been mentioned in the literature in neglected dislocations of the cervical spine. I'm talking about even the subaxial cervical spine. Significant amount of the weight has been put in neglected dislocation, and nothing has happened, because all these traction are the awake traction. Okay. So weight is according to the pathology, and obviously, as Dr. Satish mentioned, in congenital variety, you require more amount of weight, and almost 10 to 20 kg, anything can be required and doesn't cause any problem. Unless your pin start coming out. So that is important. Your hold of the pin is extremely important.
So we'll move on to the next session, and I'll hand over the proceedings to the next moderator, Dr. Manish Kothari. Dr. Manish.
Thank you, Kshitij. Fantastic previous session. May I call upon, I think all the panelists are here, Dr. Vishal, Dr. Satish sir, Ajay sir, and Sachin, Dr. Sachin. Dr. Ajay is yet to join, I guess. So we are going to talk about the CV junction instrumentation. Going to be an exciting session. Can we first start with Dr. Satish sir? Sir, can you hear me? Sir, we can't hear you.
Can you hear me?
We can hear you now, yes.
Can you see my slides?
Yes, sir.
Okay, excellent. Thank you, everyone. Thank you for the ASSI for this opportunity. Today, I will be speaking on C1 lateral mass screw technique. Kshitij has made my life easier because he has given a beautiful anatomical description, but I will repeat the same thing as he mentioned that we had to tell the anatomy before doing this, okay? So the objective of this is to see the atlas anatomy, dissection-related problems, and various entry points and the pitfalls. So as he mentioned, if you look at the anatomy of the atlas, the anterior-posterior, the length of the C1 lateral mass is about 13 to 15 millimeter. The mediolaterally it is about 4 to 4.5 millimeter, and cephalocaudal it is about 4.73 millimeter. This shows that there is enough space to put enough screw, even up to 4 millimeter screw can be inserted easily. Only thing is, it is laterally is angulated, and your angulation should be looked in a particular way that either you keep dead straight or medially to 10 degrees. The only thing you have to look at the vertebral artery position and the height of the posterior arch of the groove of the vertebral artery is when it is less than 4 millimeter, 4 millimeter, then slightly it becomes difficult to insert the screw. The anterior relation of the C1 lateral mass is also very important. As Kshitij was mentioning, if you see go dead straight or slightly laterally, you will hit the internal carotid artery and hypoglossal nerve. And this is the commonest thing. And usually this hypoglossal nerve problem, you will not anticipate immediately. The 3 to 4 months later, patient comes with a history of difficulty in swallowing. And also they will say that one side tongue is wasted and they will have a slurring of speech. So be aware of this hypoglossal nerve. So the challenges of the exposure, for the C1 lateral mass screw is, exposure related are upper border of the C1 arch, be careful with the vertebral artery. And C1, C2 atlantoaxial membrane is the, use the cob to retract the muscle, which reduces the venous plexus rupture when you are exposing. Don't use the cautery at all in these things. Venous bleeding is very crucial to expose the C1 lateral mass because there is a rich Batson plexus. And when you're dissect it from medial to lateral angle. I'll show the video how to do it. And beware of vertebral artery injury, which can happen at the superior part of the C1 lateral mass, the arch, or when you're exposing the lateral to C1 lateral mass between C1, C2 joint. And when you're creating the pilot hole, avoid, make sure if there's a venous bleed or vertebral artery injury, if you keep a plug of Surgical or the gel foam or a muscle patch, it comes in your way and it can create more problem because it can get stuck in the drill. So as far as possible, more cleaner you do the procedure without any hemostat, easier to drill the C1 lateral mass. So I will show you one by one here. So if you see here, I'm exposing the first, the first video on the left side. When you're exposing, you can see the venous plexus. I'm using the monopolar. I'm going more lateral to the left side. I'm using the heat of the monopolar, not touching the monopolar tip. So important here when you're dissecting any of the muscle tissue, this is a minimally invasive technique. You can clearly see there is a soft tissue component between every muscle and the bone in the periosteum. Do not use the tip to touch the bone or a periosteum. Go between the plane of the loose area tissue. And in this, you can clearly see the venous plexus here, which is getting exposed without any problem. Dissection and use the cork to push it. So that's the first step of preventing the bleeding. The next step of the preventing bleeding is, identify the midline. This is a C2 arch, and the midline you have to identify. There is a loose areolar tissue, and between the loose areolar tissue and the dura, coagulate the venous plexus from medial to lateral, and use the sharp scissors under microscope to cut it so that the whole exposure becomes very meticulous and you will not have any problem of the venous plexus, so that you need not, So you will not have any problem. You can clearly see I am dissecting using the hook to between the venous plexus and the dura there, so that the bleeding becomes minimal, whenever you're exposing. And go up to laterally. Superior and inferior part of the venous plexus has to be coagulated, and cut it to identify the joint, and the joint will be exposed much more easily in such a way. So here, once you come to the lateral part, you can clearly see I'm exposing the joint surface. The joint surface will be exposed and without any venous bleeding. Up to here, I have not used any Surgical or gel foam, and use only dissector, cork and monopolar and the bipolar arteries, and using the plane between the loose areolar tissue and venous plexus to expose the whole point. And once you do that, sometime when you're dissecting the C2 ganglion, you use once again the monopolar to cut it. And sometime when you use that, you had to go to the lateral part. And when you're doing the medial part between the pars and the dura, the venous bleeding happens in these patients. So that venous bleeding can be controlled. Once again, see here, the venous bleeding happens from the medial angle of the joint. And that one will be done with the bipolar cautery. So from my perspective, whole CV junction can be exposed without venous bleeding, as long as you know the loose areolar tissue and how to expose it. The vertebral artery he has already mentioned, the persistent first intersegmental artery has to be looked in. If you don't look into that, the pica, the coagulation becomes abnormal, and patient can have postoperative cerebral infarct or lateral medullary syndrome. Extracranial pica region also should be looked in, and fenestration within the C1 arch has to be looked into these patients. So you have to be very careful to see the anomalous artery. For example, sorry for the video is not here. In this patient, I'm using the Doppler. In fact, the vertebral artery is within the joint. I've cut the C2 ganglion here. The joint is completely exposed. When I'm going medially, there was the vertebral artery, and unless you use the Doppler, you cannot make out, and if you use the monopolar, you can injure that. So you have to be extremely careful whenever you're doing this. And the Kshitij also mentioned about 3 ways of entering the C1 lateral mass. The conventional method is to enter the lateral mass either with cutting the ganglion or without cutting the ganglion. In a Goel Harms technique, we cut the ganglion. In a patient's Harms technique, where we use the lateral mass with the screws, we need not cut it because the rod will come above the ganglion. Whereas in case of the Goel technique, the plate sits on the ganglion, and post-operatively patient can have C2 neuralgia. For that sake, we had to cut it. And also cutting the ganglion gives a panoramic view of the joint, and it becomes much more easier for you. The second technique is a posterior arch screw technique. Whenever there is the lateral mass inferior part is not visible, you can go through the lateral, the C1 arch. That is the second technique. The third technique is the notching technique of Lee and Ryu. I will show each one of them. In a Goel technique, the posterior surface of the lateral mass has to be looked in, and put the screw 15-degree medial and 30-degree cephalad. And in Harms technique, no need of angulation. You can go dead straight. And in Hugh technique, once again, a medial angle of 20-degree will be taken into consideration. So here you can see when you are not cutting the ganglion, you can clearly see here the patient left side is the cranial end, the right side is the leg end. Medially, you can see the dura, laterally C2 ganglion and C2 nerve root. So what I am doing is taking the periosteum from the C1 inferior arch and pushing it down till I expose the joint. And I have placed the retractor into the joint. And then I am drilling using a 2 mm burr at the C1 lateral mass, which is inferior to the joint. On the superior to the C1 arch, you can see venous plexus with the vertebral artery, and this is an angulation. Medially, I'm making an angle which is about 10-degree medial and 15-degree superior. So that's how you can preserve this, without cutting the ganglion. You can see here, double confirm the angle with the C-arm. So in case when there is ganglion excision, is very easy. I have exposed the complete ganglion, cut the ganglion, and you will have a complete panoramic view. This is the joint, and that's the hole you can create, and without any problem. Look at the whole view here. Absolutely, there is no venous bleeding at all, and I have kept the whole area with no hemostat, which will be much more useful. In the posterior arch in TAN technique, if you will be passing through the lateral mass, the blunt dissection with a pen field should be done. Vertebral artery has to be pushed away and to be located always, because ponticulus posterior has to be looked in, and entry is 0-degree medial and 5-degree cephalad. And disadvantage, if the vertebral artery is within the vicinity, it will be dangerous, and you will be clueless about the angulation of the C1 screw. And venous bleeding is slightly higher in this because you will not be knowing the depth in which you are passing through the C1 lateral, C1 arch. And ponticulus, if it is there, is disastrous. And always beware of the ponticulus. It is very, very important to use the Doppler. In this patient, I'm using the Doppler. You can clearly hear the noise of the vertebral artery when using the intraoperative Doppler. I use in every patient, whether I do the preoperative CT angio or not, I use the vertebral artery, even in the normal anatomy and abnormal anatomy, so that I'll get very good view of the vertebral artery and its position. So the notch technique is the lead technique, where the notching is done on the undersurface of the posterior arch. Done in case of the posterior arch when it is overhanging the lower 1/3 of the lateral mass. And it prevents C2 nerve irritation when you do that, especially when you use the Goel plating. And once again, either you can use the 10-degree medial and 5 to 10-degree cephalad direction. The take-home message is the conventional method is the paramount way for the lateral mass screw fixation. The key is in the dissection and controlling the venous bleeding, and use always the soft tissue and the loose irregular tissue between the muscle layer and the venous plexus, and between the venous plexus and the dura. There is a loose irregular tissue that there you have to enter from medial to laterally to coagulate the venous plexus. Consider the vertebral artery anomalous in all cases, irrespective of you have done angio or not. Slow meticulous surgery and the microscopic surgery and exposure is paramount in these things, rather than doing directly with the naked exposure. It will be very cumbersome when you use the naked eye. And do not use any hemostatic in and around the area of entry of the screw, so that your drill use become much more useful. Thank you very much.
Thank you, sir, for the excellent talk. You've actually highlighted the most important part was one was the beautiful exposure that you demonstrated. Holding the venous bleeding prevention is better than actually trying to achieve hemostasis, and that was the most important part that you highlighted. Most of us, in fact, in the preoperative planning, preoperative CT angio is the most has to be done for all these cases. As you rightly pointed out, the first intersegmental artery, persistent one, can be right under the C1 arch, right at the entry of the C1 lateral mass. So if you miss that, it's going to be a disaster. Sir, have you encountered any of these cases?
Yeah. Of course, yes. I have so far I have injured 8 patients with vertebral artery in my life. So twice with the drill, thrice with the monopolar, and 2 times when you are putting the transarticular screw fixation. Luckily, I could get away with all these patients by 2 things. One, in a transarticular screw, I have inserted the screw and did a conventional angiogram post-operatively and at the end of 3 months to rule out AV fistulas or a pseudo aneurysm formation in these patients. But the patients where I use the monopolar cutting is the worst thing, because when you use the monopolar and the vertebral artery injures, the edge become rugged, and even if you resuture, it will thrombose. I had an osteoblastoma, one patient, where I used the monopolar because I couldn't identify the vertebral artery, which was inside the tumor itself. And I restitched it under microscope using 10 ohm monocryl ethylon, but still I couldn't, post-operatively, it was completely thrombosed. Luckily, the opposite side was taking over, is a young patient, and all 8 patients are surviving today. Nobody had any posterior circulation infarct. Luckily, the cross circulation in all these patients through PCOM, the anterior carotid and the vertebral circulation is very good, because the brain is an important structure. Nature has given enough support to this. But beware, when it happens in elderly people, it'll be always dangerous. Do not do on the opposite side in an elderly patient. In a young patient, it'll be very good because of the cross circulation.
Correct. Sir, if you are not able to pass C1 lateral mass, or based on your pre-op planning, what are your parameters where you think that C1 lateral mass screw is going to be difficult, and how do you prepare for that?
So the only condition where the C1 lateral mass cannot be done in, is patients with rheumatoid arthritis, ankylosing spondylosis, or a trauma. Otherwise, the C1 lateral mass is a much more better done anatomical structure. Rarely it will be congenitally absent, except in some patients where you find the torticollis with the absence of lateral mass, where the occipital condyle can be utilized as a C1 lateral mass tube. It will get exposed as soon as the ganglion is removed, occipital condyle come into picture, you can utilize that. Whereas in a patient with the trauma, infection, and a tumor, and rheumatoid arthritis and ankylosing spondylosis, you cannot, sometimes it will be involved, the end plates will be involved, it will be too small. At that time is the only condition I use the occipital condyle or occiput C2 fixation. Otherwise, most often you will get the C1 lateral mass. At least one side you will get it.
Thank you, sir. Thank you for the beautiful videos that you demonstrated. Really enjoyed watching it. May I have next speaker, Dr. Amit Sharma? He's going to talk about C2 pars, pedicle, and laminar screws.
Thank you, Manish. To discontinue, I had a question, Manish, if you don't mind, with Dr. Udrappa. Can I ask now?
Please go ahead. Please go ahead.
So, like in some cases of significant non-reducible AAD, where the C1 is kind of tilted to the front, and how do you angle for the C1, like especially the supra-inferior angle?
Correct. These are the slightly challenging cases, because here 3 things you have to do. One, preoperative CT scan to identify the size of the lateral mass of the C1. Whenever you see in these kind of patients, the anterior part of the C1 will be bigger, the posterior part will be narrower. Very, very important. Second, the entry point will be so narrow between the occiput and this, you had to cut the ganglion in this patient and enter, and do not burr more than 2 millimeter. At that point, you put your K-wire take a C-arm picture or use the navigation to see which direction you have to do, because literally you're going inferiorly. When you're going inferiorly, the occipital squama come in your view and you cannot, enter that angle. So unless you jack the space, do not enter the complete bicortical purchase of the C1 arch, the C1 lateral mass in these patients. And you have to jack it or use the Wong technique where the spacer with a long arm, we pull the occiput backwards and then insert the C1 lateral mass. And also use the preoperative 3D models so that you will understand the anatomy very well in these patients, especially in spondyloptopsis patients.
Okay.
Entry you have to meticulously think which angle you have to put it. Otherwise, occiput comes in your view. Otherwise, you'll rupture through the lateral mass, then your anchor will be lost. And in spondyloptosis, putting the C1 lateral mass screw is most important than the occipital stabilization or C2. Your reduction becomes much more easier.
Thank you.
Rightly put, sir. Dr. Amit, may I proceed with your talk?
Yes, I'll proceed. So, Dr. Rudrapa spoke about C1. I'll be talking about C2. Now, C2 being the most robust cervical vertebra, it gives you a good holding point for even for occipital cervical or C1, C2 construct. And in case of posterior cervical subaxial instrumentation, it will give you a good construct, to have your upper end of the instrument. So in the past, I used to do C3 to C5 lateral mass and C7 pedicle screw, but now I've stopped doing that, and majority of the time I'll be going to the C2 to have that strong end-to-end construct with the C2 and C7 pedicle screw and C4 and 5 lateral mass screw. So this is one of the, I think, most strongest area where you can have a good hold of your implant. So looking at the anatomy of the C2, it has a good body. There are big pedicles. There are thick lamina. Issue is that there is a foramen transversorium on the lateral side from which the vertebral artery will pass, and it can have all the anomalies which we have discussed already. So you have to be careful. Now, as a principle, wherever there is bone, we can pass a screw, and we would like to pass a screw with the maximum diameter and maximum length to have the strongest hold. So with that principle in mind, we have three main areas of passing the screws in the C2. So we can pass a pars screw, we can pass a pedicle screw, or we can pass a laminar or translaminar screw. And this is how they will look. So pars screw is more or less going anterior to posterior to anterior rather. The pedicle screw will be going medially directed, and laminar screw will be going in the lamina. Sorry, I'll on this another one. So if C2 pedicle screw is my main workhorse which I would like to use most of the time. So it can be used for a C1, C2 or occipital cervical fusion. And as I told you, I'm using it more and more nowadays for my posterior cervical instrumentation also in the subaxial area. So if C2 pedicle screw entry point will be at the midpoint of the intersection of the parts, the facet of C2 and C3, if you extend a line from the midpoint above toward the C1, C2 joint and is midpoint of the lamina of C2, this cross section on the lateral mass of the C2, so that will give you the entry point. You can go just a tad infero-lateral to it, so you can have that superior and medial angulation, and about 30 to 35 degree of medial as well as superior angulation is required to pass the screw. You have to be careful about the vertebral artery, and it is recommended that you need to have pre-op CT angio in all the cases beforehand. Now, even after the best of the precautions, you can still have vertebral artery injuries, and it is recommended that if you have one side of vertebral artery affected, then you better instrument that side first, so that you are not kind of damaging the other side of vertebral artery. And if one side of vertebral artery is affected intraoperatively, then you better abandon the procedure and go to maybe a translaminar screw. Now, good thing about C2 pedicle screw is that they will give the strongest hold, and because they are going medially, so to some extent they are kind of trying to avoid the vertebral artery, but still there are chances, especially in case of posterior notching and very high riding vertebral artery, where the the diameter of the pedicle can be very narrow, and you can actually go in the foramen transversorium. C2 pars screw. So there are different versions of the C2 pars or isthmus screw in the literature. So whenever you are passing a screw in the lateral mass of the C2 and it is not in the pedicle, then like literature has kind of called it a C2 pars screw. So there are various ways by which you can pass a C2 pars screw. So the most common way is like entry point is in the middle of the lateral mass of the C2, and your angulation is straight to the front. Now, as Kshitij has said, that if you want to avoid going into the foramen transversorium, your length will not be more than 14 to 16 millimeter. But there are different versions which go like cranially and to some extent medially also, where you can pass a size 20 screw as well. C2 pars screws give strong hold. They can go straight in. If they stay shorter, they are very safe. But again, a pre-op CT angio is recommended. And for me, they are like, not even second option. They are the third option after the translaminar screw, because I will not get that strong hold in the pars screw as I will be getting with the pedicle screw or a translaminar screw. So you can have a what they call a superior pars screw, which is going from the little superior entry point straight in, or you can have an inferior pars screw, which is going from the little lower entry point, but directed little cranially. And this is how they will look. So superior pars screw has more probability of avoiding the vertebral artery, but if you're putting the inferior pars screw, then your screw length will be less because you don't want to enter the foramen. C2 laminar screw can be utilized it's mostly used as a bailout procedure when you are not able to pass the pedicle screw, whether they are anatomically not suitable or intraoperatively you had some difficulty in passing the pedicle screw. So they can be passed bilaterally, as a choice when the things are not suitable to start with, or they can be passed unilaterally when you have you were not able to pass pedicle screw or pars screw on the one side, and you can just utilize the thick lamina. Now, the entry point is at the junction of the lamina and the spinous process. So now one thing is we have to be careful. If you are passing two laminar screw, they have to be staggered. So one entry point of one screw will be higher up compared to the other one, because otherwise they'll cross each other. And because if you start from the left side, you are actually passing the right side laminar screw, and vice versa. So their entry point need to be staggered if you are planning to pass two laminar screws. So they are mostly bailout option. However, the biomechanical strength is good enough to kind of justify their use in cases of especially in the occipitocervical instrumentation. They have more failure in subaxial instrumentation, but for the occipitocervical or C1 C2 fixation, I think they are good enough. Again, for them also pre-op CT is recommended, and we can easily pass it. Most of the time, it's recommended that you pass a 3.5 mm screw only to leave that 1 mm margin on each side in a 5 to 5.5 mm thick lamina, and a size 26 or so of a length screw can be passed easily. Now, what we want is with a screw that it has to be enough. It has to be having enough biomechanical strength. It has to be safe. So biomechanical strength wise, different literature says different things, but more or less the C2 laminar and C2 pedicle screws are having like same hole in the bone. Compared to that, C2 pars screw will have lesser hold. But again, it's not about the hold which we are getting. A biomechanical superiority may not be translated into the clinical advantage. As long as hold is good enough and you have done a good job with the fusion, I think the job is well done. Now, in terms of the accuracy, the translaminar screw, because we are able to see them at least from the outside, and with the pedicle sound, with the sound technique where we are passing that instrument to check the integrity of the lamina, and passing a Woodson elevator underneath the lamina to make sure that there is no internal breaches, the accuracy has come to around 95 to 100% for the translaminar screws. Pars screw accuracy is little less than that, and the pedicle screw falls somewhere in between. Now, in one of the article, interestingly, they have mentioned that there was no difference in terms of the pars and pedicle screw between the navigated and non-navigated techniques. Now, in terms of the safety, the translaminar screws are safest because their accuracy is good and they are far away from the vertebral artery. Pedicle screw, their accuracy is good, but they can have a medial breach, and can irritate the spinal cord. However, as Dr. Shrivastava mentioned, that we have the canal in this area is quite capacious, and actually I also had a case, subaxial fixation, where post-operatively I found that my screw was, though intraoperatively it had a good hold, but it was, it was a grade 3 breach, which was not detected intraoperatively. But because the hold was good and the other side hold was normal, so I kind of, and patient did not have any post-op neurodeficit, I kind of just sat on it, and it turned out to be well at the end. Pars screws can injure the vertebral artery if they are too long, and if, especially in an inferior pars screw where you are kind of directed toward the foramen transversorium. Now, C2 laminar screw can have cortical breaches. They cannot be used. Obviously, if you had to do a laminectomy procedure on the C2, and many times because they are not in the line, you have to use a connector to connect it with the rest of the instrumentation. So that's one of the problems which we face with the C2 laminar screw. C2 pars screw strength is mediocre, and they can penetrate the vertebral foramen, so that's their peculiar problem. The C2 pedicle screw can have a medial or lateral breach, and now in this particular article, the vertebral artery injury incidence is 4 to 6%, but I think it all depends on how meticulous you are during the surgery and how much pre-op workup you have done to avoid any kind of disaster. As Kshitij has shown this picture, the safety kind of increases as you go away from that, transarticular screw toward the laminar screw. But again, it's all about which procedure you are more comfortable with, and which kind of anatomy is available for that particular patient to have the best instrumentation. A pre-op CT angio is must for all the cases. A significant percentage of the pedicle screw especially may not be suitable. Breaches are common, but a grade 1 or 2A or 2B breach is not, a disaster, and you can still get away with them. But neurological injuries are rare, as I told you in my case, where even with the grade 3 breach, things were okay. And last but not the least, it's the fusion which will save you, because the aim of the implant is just to hold the spine till the time fusion takes place. Thank you.
Thank you, Dr. Amit, for this wonderful talk. Just for the preoperative planning, so I always use the CD of the CT scan. I always see on the system. I never use the plates to kind of take measurements or decide what screw I'm going to use. You kind of realign the images as per your trajectory of the screw, especially the pars is slightly medial, so is the pedicle, and the level where the vertebral artery comes in for your pedicle screw. To determine the diameter of the C2 pedicle. That also will depend on what axial level you are taking it as. So how do you do it, Dr. Amit?
You are absolutely correct. CT is one investigation where I will ask the patient to always bring a CD from the imaging center, and I'll put that CD, and nowadays I'm using Horos software. So as you said, we had to, the technician from the CT center would have given the cuts as per their, their liking. But we would like to have those cuts taken at our desirable plane. So I always upload the CD in my Horos software and take the cuts as per the planning. So yes, always. And even even for a post-op patient, sometimes I would like to have the CD to assess the fusion, whether it has taken place or not, whether the screws are in, because they don't know what we are looking for, the radiologist most of the time, unless you specify to them. So yes, we have to evaluate it.
So moral of the story is always have a thin cut CD for your evaluating your CT scans. Take the appropriate images to make your measurements. Moving on to next talk, we have Dr. Vishal to demonstrate minimally invasive C1, C2 transarticular screw. He's an expert on it. May I have Vishal? Dr. Vishal is here.
Hi, yeah, I'm here. So I'll share my screen if permitted.
Yes, please.
Is my screen visible?
Yeah, visible, Dr. Vishal.
Okay, perfect. Thank you. So transarticular screw, I think it's one of the most enigmatic implant fixation for craniovertebral junction. And most of us have known transarticular screw for the bad name that it has earned over years because of the problems that some surgeons have faced in the form of vertebral artery injury or the technical difficulties that are accompanied with this particular technique. However, transarticular screw to me, I think, is one of the most safest, simplest, easiest way of fixing atlantoaxial instability, particularly in patients with a broad pars of C2 and a reducible atlantoaxial instability, which is actually the case in more than 80% of cases of AAI with cervical myelopathy due to CV junction instability. And that's why this surgery can now be performed within like 30 minutes and both the screws can be there. And the fusion rate and the benefits of transarticular screw are so easy that, I mean, they cannot be overemphasized than what they actually are. So atlantoaxial dislocation, we all know the symptoms can be varied. It can be mechanical, like it happens in more than 80% of patients. They don't actually have a neurological finding to present with. And many of them are actually asymptomatic. They would just turn up with a mild neck pain in subaxial region, and on a radiological investigation that you find that there is a atlantoaxial instability. But it is very important to catch them very, very early in the course of problem, to fix them early and to prevent catastrophic symptomatic myelopathic symptoms in these patients, which invariably are irreversible by the time they set in. And to manage them, there are various ways of fixing them, involving the Harms and Goels technique, wiring, and various other techniques. Magrill-Neo technique of transarticular screw fixation gained weightage in 1983, where it came into existence, and it has shown to be promising results in fixing the C1, C2s. Every technique has its own pros and cons. However, transarticular screw, which initially was described with a bone graft being held with the wiring technique, had very, very high fusion rates. Of course, there were downsides of wire loosening and very difficult technical difficulties during particularly cases with high riding vertebral arteries. However, over years, because of the simplicity and very high fusion rates, it has become the gold standard of C1, C2 fixation, particularly in a certain subset of patients where there is a reducible atlantoaxial instability, not only because of the high fusion rates, but also because it has achieved the most solid fixation in the CV junction, even better than the segmental C1, C2 fixation techniques that are described already. So what is transarticular screw fixation? It is basically a screw that goes from the C2 lamina through the C2 pars into the C1 lateral mass, fixing the joint in three-dimensional manner because of the obliquity of the screws that goes in there, not only giving a flexion extension related stability, which is absolute, but also the rotational stability achieved by transarticular screw is absolute and far superior than any other comparable fixation technique in C1, C2 area. And it also ensures, because the joint is gone, it is fixed in an oblique manner, it also ensures 100% fusion rate in most studies, including ours that we have published over the years already. Now, transarticular screw is one implantation technique where the preoperative planning, I think 90% of surgery of transarticular screw happens even before the surgeon actually washes in. And it actually has only three basic phases. And if you have gone through all these three phases, even before your surgery actually starts, you would have finished this surgery well in advance. And it involves feasibility, whether it is possible to do it or not, reducibility of C1, C2, whether C1, C2 is reducible or not, and then whether the trajectory has been planned or not. If these three things, you have studied your images in great detail, they can be ensured that it is feasible, it is reducible, and the trajectory of the implant is positioning and the implant inventory is planned very well in advance. The surgery per se will become very easy to perform intraoperatively. And the planning actually starts by ruling out the contraindications. Most of the surgeons have actually faced technical difficulties when they have attempted transarticular screw in patients where it was actually contraindicated or it was not feasible to do. So you start with the first thing, that whether it's a irreducible AAD or it's a reducible one. If it's irreducible, please take away. You cannot do it in irreducible ones. In malunited ones, again, you cannot do a transarticular screw. It has to be a reducible one. In high riding vertebral artery, it is recommended, at least for the beginners, please don't attempt any case of transarticular screw in patients with high riding vertebral artery. And if you see that the pars through which the screw is going to go is less than 3 millimeters in diameter, you please do not attempt a transarticular screw, because the thinnest screw that is available, cannulated one pass through the pars currently in the market, is of 3.2 millimeters diameter. So the minimum diameter of the pars required to accommodate that screw has to be about 3.2 millimeters in diameter there. Again, for the ideal trajectory, any thoracic or cervicothoracic hump will prevent or preclude the insertion in an ideal trajectory. And that's why thoracic kyphosis to begin with, please do not attempt a transarticular screw. You are going to meet a disaster of getting the screw inferiorly placed into the vertebral artery transection there. Once you are ruled out, again, this is something that we have published also, that the MPD or the minimum pars diameter should be more than 3 millimeters if you want to have an intraosseous placement of the transarticular screw in there. It's imperative to have true AP and true lateral images when you are doing a transarticular screw, so that the two cortices of the pars are seen to understand whether it is atlantoaxial dislocation with more than 3.5 millimeters of pars at the diameter intersection of the pars there. These are the cases where a wonderful transarticular screw can be done. During surgery, you should also be able to see that the reducibility quotient has to be there, and this usually happens with a military tuck position where the chin goes back, the neck goes straight, and this also reduces the thoracic hump, which is positional in nature. And this has to be replicated during the positioning of the patient in prone position. Now, when it comes to reducibility, we often say that, or we often assume that atlantoaxial dislocation is irreducible. However, till date, most preoperatively seemingly irreducible ones can actually become a reducible atlantoaxial dislocation if you apply all these maneuvers there by either using a wire on the C1 and pulling it back, or giving a traction preoperatively, or even a C2 push technique, or by doing an intraoperative distraction using Pukka, as you can see in all these images, that the seemingly assumptive irreducible C1, C2 dislocations actually were reducible ones. The moment you put these patients under GA and put them prone and do these maneuvers intraoperatively, even before your incision comes, you can actually reduce most of them, if not all. So even before you just shove away that transarticular is not possible, please try and see if you can. Always keep transarticular in your inventory, because this can actually save a OC fusion into a segmental C1, C2 fusion, preserving the OC joint for further mobility there. Now, once you reduce this, transarticular screw is a C-arm guided image. All these maneuvers will help you to reduce them, and it has to be done under C-arm guidance all the times, while every step of your intraosseous drilling is happening there. And as we mentioned, at the pars diameter, there are so classical Magral neoclassification mentioned about a fixed entry point, whereas the way we have been doing it is that there is no fixed entry point. It is actually the entry point is the retrograde projection of the exit point. So for us, the exit point is fixed. We always aim that the tip of the screw, the exit point is in zone 1 and zone 2, which is the upper part of the anterior arch of C1. This is the point where the tip of the transarticular should always reach, and then retrograde projection of this through the midpoint of the pars, wherever it falls on lamina, becomes the entry point. And that's why it is a tailor-made entry point rather than a fixed entry point, in inverse to the Magral Neo's description of the entry point. So the entry point is never fixed, but the exit point is always fixed, so that you can get an ideal trajectory and avoid any vertebral artery perforation in these patients. Coming to the draping part, we all know that it's a percutaneous screw, so the draping should be all the way from mid of occiput to the T3 level should always be seen, so that your percutaneous implants can go, because the percutaneous guide wires and the screws actually go from the T1 point or T1 or T2 spinous process, and that's why the draping should be wide enough there. I always do this procedure under microscope, and the inventory involves keeping the smallest possible cannulated screw, even the Herbert screws. So we have been doing this for years now, and now with expertise over years and the learning curve, we have been able to do the same with the help of 2.5 millimeter Herbert screw also, particularly in pediatric and dysplastic pars. We have been able to do this. However, I would recommend that please don't do it in your initial first 50 cases. Try to do it only when all the contraindications have been ruled out in all patients. The incision is a midline incision based on the C2 spinous process. As we go through the surgical steps, we will see that's the trajectory. Preoperatively, we have to see that the exit point is fixed and the entry point is always tailor-made.
The dorsal surface of the pars is laterally.
And these are the points which we see intraoperatively on the CM.
And come out in the center of the.
So that's the surface anatomy, how the screw goes. The incision is placed on the center of the C2 spinous process. The exposure is limited only to the C2 lamina and C2 pars. I never expose the O and C1 junction to avoid inadvertent OC1 fusion, and never expose the C2-3 joint there. The incision is hardly 3 centimeters, and because it's under microscope, the space between the C1 and C2 has to be felt, and the cautery has to be kept very cautiously used, so that you don't puncture the C1, C2 membrane there, and also the dura, which is so superficially placed there. Cautery always runs on the bone and goes all the way from the C2 spinous process to the C2 lamina. Once the C2 lamina is seen, then a blunt dissection with the bovine using a patty is done to walk on the surface, dorsal most surface of the C2 pars all the way into the joint there. I think that's the only part of the surgery that you have to be really extremely cautious, that your cautery should not really go laterally. Otherwise, the vertebral artery foramen is very near there. So it's blunt dissection. Always your bovine runs only on the bone, and between the C1, C2 goes all the way lateral to the C2 ganglion there. You always walk on the C2 lamina with the help of your patty and bipolar cautery. And this patty walks on the dorsal surface of the C2 pars, and you actually enter into the joint all the way there to see the joint there. Once you've seen the joint, the whole pars, the dorsal surface of the pars is already seen. And in the C-arm, you can actually, through the exit point that you wish to achieve and the dorsal surface of the pars, your screw can actually be walking right in front of your vision there. So that's the whole pars that is visualized there. And once you visualize the whole pars, the entry point obviously can be retrogradely projected where your entry point is going to be. So this is one of the most difficult cases. The pars diameter is only 2.8 millimeter. And yet we were able to achieve a fixation with transarticular screw there. Both sides. This is the very, very important step I recommend, is that always walk on the pars, the dorsal surface of the pars with the help of patty, and enter into the joint with the help of your McDonald's or a blunt pen field retractor there. And once you've seen the joint, it is right in front of you on the dorsal surface, and you can actually walk working on the most dorsal aspect of the pars there, and your guide wire can run through this. Once you've seen this, you can actually burr the joint surface out there even before your guide wire can go in there. I generally tend to curate out the cartilage there, and visualizing the pars and the joint is the most important aspect of this surgery. And all this happens under C-arm guidance. My guide wires walk. The entry point is then burred. The incision is at T1 for the guide wire. The guide wires then walk through from the entry point right in front of your vision.
Yes, sir. Yeah.
And guide wires through percutaneous
incision. I will send you. Can you just tell me your...
With the help of a sleeve, land on the entry point, and the guide wires then under C-arm guidance.
Yeah.
Just touching the most dorsal surface. At all points, the guide wire is kept under control under C-arm guidance.
I will tell you Kshitij also to send you, okay? Don't worry. Sure. Yeah, already started. Okay, but you are in the next session. So
at all points, you can actually see the guide wire is walking right in front of you. You can actually see the guide wire passing through from C1, from C2 all the way into the C1. And once your guide wire is there, just tap it. It is just like passing in a DHS screw. Once your guide wire is in there, you tap. It's a cannulated hand drill. Make sure your guide wire is under control, because sometimes the guide wire can just walk across and anteriorly go and touch the hypoglossal nerve there. And on this walks the C2 screw. And all this, again, as I mentioned, it's a C-arm guided procedure. At all times, it is under C-arm control, so that the guide wire just walks at the most dorsal surface of the C2 right in front of your vision. The exit point, as we have targeted in zone 1 and 2. And then the graft is inserted in the joint and on the posterior surface. I always use the allograft, which is morselized and kept on the surface, onlay graft. And people who doubt this, that whether fusion happens or not, our studies have shown 100% fusion rate. Some of the case examples, before I just finish there, traumatic non-union odontoid, again done with a pure C1, C2 transarticular screw without any wiring technique with morselized allograft. Avulsion chip fracture of the lateral mass with transverse ligament rupture, again managed by transarticular screw. Another case of road traffic accident with subtle transverse ligament ruptures resulting into a reducible C1, C2 dislocation managed by transarticular screw. Wonderful fusion mass seen there. Reverse oblique odontoid fractures in elderly patients, transarticular screw comes very handy, and you see the fusion rates are almost 100%, particularly in comminuted osteoporotic fractures in elderly patients. C1, C2 tuberculosis, again, in these patients, if the lateral mass of C1 is intact, you can really depend on this technique and it fuses like fire. Rheumatoid arthritis, osteoarthritis, inflammatory arthritis. In kids also, we have used this and it has shown wonderful results out there without any problem. Even in dysplastic anatomies, now we have been using it, even in pediatric challenges. And now to an extent that in dysplastic patients and in pediatric patients, even a 2.9 millimeter pars can accommodate a Herbert screw of 2.7 millimeter. Some case examples even in high riding vertebral artery. And now we have been using OC fusion, where the C2 becomes a solid construct, where the C2 screw is the end point of the cervical fixation in patients with syndromic, like in this particular case where there is anomalous C2 with AD and BI, which so-called irreducible became a reducible one. And you can see the transarticular screw, which is a solid construct there, so as to avoid any need to go down to C3, 4, and 5. Some case examples very similar to syndromic Klippel fields and Arnold Chiaris.
Thank you, Dr. Vishal. I think we are running a bit late. If you permit, can we go ahead with the next talk?
Thank you.
Thank you, Dr. Vishal. Dr. Sudhir sir is going to talk about wiring techniques. With all the new instrumentation techniques, the wiring techniques are still going to be a sandwich, and they are an important part of your knowledge base when you're tackling C1, C2. On to you, Shrivastava sir.
Yeah, I will say. Yeah. Thank you, Dr. Manish. So as mentioned, bone grafting and wiring technique. I will just a minute. If this part is actually not coming, I will just hold on. Yeah. So I'm going to talk about this fusion technique in this occipito-cervical region and what are the tips. We must be aware about the realities that this area is extremely mobile region full of ligaments, and there is a poor bridging bone, and there is a shallow joint, and chances of delayed union and non-union and implant failure are common if you have not done this fusion properly. We know that as far as the bed is concerned, the proximal bony bed is the occiput, which is a thick cortical bone, and we must bur it to make it good osteogenic bone. There should be a bridging graft, so there is a gap between occiput and C2 or occiput and C1, and we should try to bridge the graft. Then only this is going to unite. So these points are important and one should take into consideration. Now, just putting the graft or throwing the graft in that area is not going to solve the purpose. Actually, the graft which you are putting there, that should be stable enough to bridge that area. So try to increase the fixation to this graft to that area, whatever way you are trained in. Now, there are different elements. Osteogenic bed starts from the occipital area. And you can see this is a cortical area, and you have to convert by drilling or burring this area. So OC joint is another area where one likes to put the graft if you want to restrict from occiput to C1. The posterior C1 arch you can use as a bed, and then C1, C2 joint. Lamina and spinous process of C2 is another area which function as a good osteogenic bed. The bone graft fibula has been used since long, from old days, almost 1920 it has been mentioned, but the non-union rate was very high, it was almost 40%. The triple wire method of Bollman has been nicely described. Actually, people started putting bone cement to stabilize this thing so that it unites. Now I'm going to show you the graft bed preparation of occipital region. Now here I have already done the occipital cervical fixation, and you can see this whole central area I have burred. And now you have to shape the graft in such a way that it bridges the area and it gives a good stability to the graft. I'm just running this video.
We can't hear you, sir. Shrivastava, sir, we cannot hear you.
Hello.
Yeah, we can hear you now, sir.
So from the beginning, you were able to hear me or not? Hello.
We couldn't hear you for the last 30 seconds, sir.
Okay, when this video is started?
Before that, sir.
Okay, okay. Okay, take care. Bye. So let me go to first thing. So I will start from here.
Yeah.
This part, it is okay?
This we've covered, sir.
No, just before the video, sir.
Just
Yeah.
before the video. Okay. This I had covered.
Yes, only probably the video.
Okay. So this, I was telling that I have done this occipito-cervical fixation. The occipital area I have made raw by burying, and I harvested the graft from the iliac crest. I usually give this inverted Y-shaped structure to the graft, and I'm going to make a drill hole, and 2 drill holes will be made. And this arm of this inverted Y will be sitting on the spinous process of the C2. I have already put the cancellous bone in this bed. And on the top of it, I'm going to put this inverted, Y-shaped graft, and I'm going to tie it. Now, this is not going to move, and union is very sure in such situations. Now, in tuberculosis, there is a significant destruction of the lateral mass, and you are not able to put any implant there because it is almost loose. Nothing is going to hold there. So in this case, there were a lot of pus. I drained through it, and almost you can see my probe was going front. There was no bone there. So in this case, again, we have done this occipito-cervical fusion, and this is the implant which is hard-sealed rectangle and sublaminar wire. So you can pass the wire from the occiput, and then again, the answer is good bony fusion. You can see there is a bridging bone graft from occiput to the lower down, and add extra cancellous bone, and this ensures fusion. Another case of pediatric occipital cervical area where tuberculosis was again the pathology, and here you can see the bridging of this has been done with the same thing, hard-sealed rectangle, sublaminar wire type of thing, and this wire, the cut end of the wire, I have bent on this strut graft so that you give extra stability to this graft, and the fusion almost you ensure that this is going to fuse, and so this is a stable column. Another case, significant destruction, no bony structure to hold in the C1 and part of the C2 area, but I could manage to pass C2 pedicular screw. And this inverted shape, again, this graft I have shaped according to the space available in the bed and added a few extra cancellous chips. And such, fusion, meticulous fusion is important in such situations. Now I'm going to show how to make bed in the C1 and C2 area when you want to fuse C1 and C2 only. Don't disturb occiput in that area. So burying of this C1, you can see the posterior arch and burying of the lamina, and then harvesting the autogenous graft from the iliac crest, almost like a same shape I have given. Make 2 holes, and then make a corresponding hole in the spinous process of C2 and pass that vicryl, which you have already passed through that graft. This is the way you should pass. Another hole has been made, which will be fixed in the C1 posterior arch and tighten this. You can see it is quite away from the occiput. Put additional cancellous chips. Now, wiring technique, this galleys fixation is an age-old technique where the wire is passed beneath the posterior arch of the C1. It is actually turned on this C2 spinous process just underneath, and then you put a graft and tighten over this. So this wiring technique is important and one should learn it. The many times if you are not able to have a screw fixation because of so many regions, these are the bailout technique and one should be aware about this. One should learn this technique. This is the Brooks wiring where this wire is passed beneath the C1 posterior arch and also the lamina of C2, and it is passed both the sides. So this is rotationally more stable, and you can put bone graft in between and you can have a good fixation and fusion. This diagram I have taken from the old age literature where this how this stud graft has been tied with the wire from occiput to lower down. So these techniques have been used earlier also, now also. Sometime if you are not able to manage to have fixation, this is the bailout technique and one should be aware about that. I have just taken a small video clips. This is for occiput, how to pass the wire in the occiput. So you make drill hole, 2 drill hole, and in the center part your either rod and the Hartzell rectangle arm is going to go. You give a specific curvature to the wire. So this stainless steel wire pools, you can just cut one and give this bent. Now giving this bent is important so that once you try to insert from one side, it gets delivered on its own with a gentle manipulation. So that should be the shape, and you insert from one side and then you can see here. Here you can use K-wire tip or you can have a skin hook and just engage that. And this is the way this maneuver is important. You bring it and so gently it comes out. You have not to push it. So this has been passed. Now for C1, and here actually I am going to show the galleys one. Run it. So clear the soft tissue, you have to go subperiosteal, make a space there, and here you see the size of this loop is different from occiput, and it gets delivered very nicely. Now here either you can pass this loop one beneath the spinous process of C2, or some modification you can also do. Here what I am trying to do, I am inserting those cut end and then I will be inserting beneath. Otherwise, when you wish to put this loop beneath the C2 spinous process, you have to cut the interspinous ligament. But here this can be inserted without doing this and then make it twist. So this is the modification of this galleys fixation. Now this is for C2. No, C1, yeah, this is for the C1 posterior arch. So the previous one was for galleys, this is for posterior arch. And once you pass it, lock it there so that it doesn't move when you are doing the procedure on other side. Now this is for C2. You can see now there's a transverse limb of this bend is different from the upper because that is the usual breadth of the C2 lamina. So clear that area and this pass it. Gently with the little gentle manipulation you can elevate it, again lock it. So these were the small clippings which I wanted to show. Now this is the last case which I wish to show you. Now here the 77 years male which we operated for this AAD, and he was fine. This was our planning and we did occipito-cervical fixation and fusion. This was the child, he recovered neurologically. he had a fall and he again came back, and see the prominence of the implant here, swelling. So, and he started developing neurological deficit. You can see the plate has come out, and you can see the CT is just so much of the distance here. It has again started having displacement. And so here again, the bailout technique is wiring. So this part is away from occiput. This screw I took out, and then we made a hole in the occiput, and we can put past the wire. So this was the planning. From one side, the central hole, I passed the wire, and another side, we passed the another wire in the occiput. And this is important. A simple instrument which you just require a needle holder and stainless steel wire. You make a loop shaped and give a curvature in such a way that it gets released through that hole nicely. So you can see passing the wire from this part and this part, central part in the one side. So wire on the left side and the central part, and then you can see a lot of bone graft we put again. This is the way it got aligned again, and you can see the wire passing to the occiput, and he improved neurologically. So I will conclude the proper fixation of the occipito-cervical region, proper osteogenic bed preparation in occiput and atlantoaxial region, laying down and stable bridging of good quality cancellous or cortico-cancellous graft almost ensures sound occipito-cervical fusion. I thank you very much for your kind attention. I will stop sharing.
Thank you, sir, for the beautiful demonstration. Any questions from any of the faculty? So you've very nicely explained that the preparation of the bed is the most important part of laying down the graft. You've shown how the H shape, the notch of the C2 is to be made. You drill the wires, and you secure the graft with the help of the wires also. So any difficulties you've had, sir, passing the occipital wires?
No, actually, how you bent the tip, you should suppose your two holes are quite apart. So you have to make a larger diameter, that bend. So according to the distance between two holes, you have to make that loop. And when you are making the loop, bend the wire just 3 to 4 centimeters, so that insertion also becomes very easy.
Right, sir. So if there are two tables and there's a cancellous area in between, I'm assuming it is going to be very easy. But if the entire occiput area is a bit cortical or sclerotic, so does that pose any question, or it does not matter?
No, actually, good cortical bone is at your advantage, because you are making hole through both the tables. Okay, you are not making hole through one table, both the tables. And so this fixation, see, in all this infective pathology, the posterior bone, the cortical bone is a good quality bone, and in fact, purchase of the implant on this good quality bone is better as compared to the screws. So it is actually, it is not the screw which holds the bone, it is the bone which holds the screw. Rather, this wire it holds the bone nicely. So I think cortical bone is a good quality bone, and it gives better and stable fixes.
Right. We don't have. Thank you, sir, for that excellent insight in cervical wiring. We don't have Dr. Upendra here today. We'll just take quick questions from the master of cervical pedicle screws, Dr. Abumi. Are you around? Abumi, sir. All right. Right. Okay. I think we'll go ahead with the talk. Next talk, we'll invite him again. Yeah. So I'll be presenting on the odontoid screw fixation, anterior odontoid screw fixation. So anterior odontoid screw is a very elegant technique. The prime interest in the screw is that it can save the movement at C1 and C2 joint. but you have to be careful where you use it. So it was first described in by Bolas in 1982. It provides immediate stabilization, direct osteosynthesis instead of you waiting for fusion and a segmental fusion, and also preserves the rotation of and movements of the atlantoaxial joint. It is an anatomical synthesis. So before you look at the screw, you have to obviously know the anatomy of the C2. So there is a watershed area between the odontoid and the vertebral body. That's where somewhere in this area at the level of the articular facets. And type 2 type 2 fractures are the one which are amenable for odontoid screws. Now Gower described 3 different types where you can use or where you cannot use that odontoid screw, primarily because we were seeing some failure of the odontoid screws, and that's when the classification came in. So there's a type A, which is a horizontal one, a type B, which is the forward oblique one, and a type C, which is a reverse oblique one. So if you just kind of use common sense, the type C is almost parallel to the trajectory of the odontoid screw, and hence it should not be used in a type C. It's a contraindication to use in a type C. It is safe to use in a type A and type B. So as I said, contraindications are in type C. If there is a gross transverse atlantal ligament injury where there's going to be a delayed C1 and C2 instability, your odontoid screw is not going to prevent that. It is just going to heal the C1 and C2. But having said that, to have a transverse atlantal ligament injury and odontoid fracture type 2 is very rare. Third is the trajectory based, the technique based. If the patient is barrel chested, then you may not be able to get the trajectory required. We'll talk about it in the subsequent slides. If the bone is too osteoporotic or it is too sclerotic, they both may be a relative contraindications because you may or may not be able to achieve and drill it. So that will come to it later. If the bone defect is very large, generally you see large bone defect at the fracture defect. If the presentation of the patient is late, there is resorption of the bone and there is fibrous healing in that area that is going on. So if it is more than 3 mm or it is very old, then you may not be able to achieve direct osteosynthesis, same principles as you would use in long bone fractures. So selection of implant, various types of screws are available. You can use partially threaded ones. You can use the Herbert screws, or you can use differential thread screws also. Having said that, you must keep a posterior C1, C2 segmental instrumentation. If in case you are not able to achieve a good reduction or a good fixation, you should be able to flip the patient and do a posterior C1, C2 fixation. Position is supine like in HCDF. Head should be absolutely stable. You cannot afford to have the patient, the head turning side to side. I generally prefer a Mayfield clamp, or you can also use some form of tongs along with traction, just minimum traction to give the reduce the fracture and stabilize the head. Don't use too much weight if you're using traction. Keep a gag in the mouth to allow an open mouth view of the Siam. And many anesthetists for spine by default use these armor tubes. You see these are the armor tubes. They have rings in them. Please tell them beforehand not to use the armor tubes because that will prevent your AP imaging. So use a simple tube, or rarely you can also use a North Pole tube which goes through the nose. So this is, I'm looking at the trajectory now. So I've positioned the patient on, this is a case of an angstpon. I've positioned the patient on Mayfield clamps. He also had a subaxial C4-5 dislocation. So this is what the position that I achieved with the neuromonitoring. He had deficit. And now I'm trying to look at the trajectory. So you see that metal piece here. So that kind of gives me that the chest is not going to come in my way of the trajectory because the instrumentations are long, the guide wires are long. You need a very long area above the chest up till the xiphisternum. You should be able to kind of get access and have room for your instruments. So next is you have to achieve reduction on the positioning itself. Do not wait. You cannot achieve reduction, or it is difficult to achieve gross reduce a gross displacement while you're passing the screw. So all efforts should be made to reduce the screw on positioning itself and fix that position and make sure you strap the patient and it does not move. Some movements can happen. In this case, I was in the case, there was some retro displacement of the odontoid, but there are ways to manage it. We'll come with it later. With regards to the setup, if you are a right-handed person, you use the right-sided approach. If you're a left-handed person, you use the left-sided approach. Same for ACDF. I always use two C-arms, one for AP and one for lateral. I don't recommend doing this screw with a single C-arm. It's very tedious. I've never done it. I don't recommend doing that also. In a lesser setup, you may want to attempt it, but it's I would rather not attempt it. So the lateral image, if you see the C-arm, this one is tilted horizontally. It's not coming from below or above. It is tilted horizontally, and the C-arm is coming in this direction. And the AP image is coming from the opposite side. So you are free completely on this side. Yeah, you may or may not be able to get the microscope in. So keep loops and headlights handy. But most of the technique is actually under C-arm. So microscope is not of major advantage here. Next, once you get the trajectory, you do a standard ACDF approach at around C4, C5 level. Push the omohyoid down. You did not cut it because you're going cranial. Once you land on the C4-5 disc, you just walk yourself up to the C2-3 disc. You see this right angle is a long Langen back, long and a broad one that goes right and sits right up to the C1 arch, because you need to lift that entire retropharynx slightly upwards so your instruments can reach directly at the C2-3 disc. You need to have a good, strong assistant to continuously maintain that. Now, regarding the entry point, you can take either the anterior lip, which is just at the anterior inferior corner of the C2, and there are other technique called as the end plate technique, which burrs the disc about 2 or 3 mm and enters around 4 mm from inside the disc. If you see, the C2 has a slight lipping at the anterior inferior border, so it does not necessarily damage the C2-3 disc, and this also has been described in literature. Why this has been described is because you get a more vertical trajectory. If you take a very anterior trajectory, then you may not end up at the tip of the odontoid. You may end up somewhere at the posterior cortex. Regarding the entry, so you can nibble the anterior lip. It is safe to nibble that part, or you can drill it as you want. And you can either use 2 screws of 3.5 mm, or you can use a single screw of 4 mm. Most of the Indian population, you can use a single 4 mm screw. It is difficult to have 2 screws in most of the Indian population. Accordingly, you kind of adjust your trajectory. If you're using 2, then you use 2 parasagittal entries. If you're using 1, then you use a single midline entry and try to stay as straight as possible. So in this case, you get the trajectory. That's the entry point. You're drilling that area and you're trying to enter the posterior corner of the dome of the superior part of the odontoid. Now, next is the sagittal plane. As we said, you are trying to aim into the posterior half of the tip of the odontoid, and you try to get a bicortical purchase. Now, this part in the elderly is going to be sometimes very sclerotic or completely hollow. That you have to decide on CT scan and take a call what you can achieve. If it is too sclerotic, then you can still drill it, your hole will be good. But if it is completely hollow and there is not much bone, then you will have to aim to engage the posterior cortex here. In the AP view, you want to be dead midline right in the center, right at the tip. Try not to go to the sides for a single screw. When drilling, I use the oscillating drill attachment. There are 3 attachments in the drill. There's a forward, there's a reverse, and there's an oscillating drill. I prefer oscillating because it reduces the chance of ensnaring the tissues around the wire. Although you are using the guide drill here, but an oscillating drill is a safer way of preventing soft tissue injuries. When you are drilling, make sure you don't penetrate the odontoid tip. So this is the odontoid tip here. You make sure you don't penetrate that, because right behind is your pons. If you injure the pons, then it's going to be a disaster. Now, regarding the reduction, if you see that in this case, I don't have 100% reduction. There is a step here. There is a retro displacement, posterior displacement of the tip. So you can just gently put your finger. Once you pass the wire in caudal to the fracture, somewhere here is the fracture. Your wire is just reaching the fracture. And once you are reaching the fracture, you press the C2 body posteriorly to align with the C2 odontoid. These minor movements you can do, but gross adjustments are difficult intraoperatively. And then you pass the wire in the posterior half of the odontoid. Then you drill it with a cannulated drill. Again, make sure wire migration is the most important step. If you're drilling too aggressively, if there is a bend in the wire or the wire has already penetrated the cortex, then it's very likely that you're going to push the wire further inside. That should not happen. This part of the surgery should have maximum shoots. Every millimeter by millimeter you have to go. Once you have that, the length measurement is most important. Allow, depending on the defect, allow for a correction of, as the fracture collapses, there's going to be some loss of length. So if you measure, say, around 44, you take around 42 or something like that. Otherwise, your screw will be a bit longer. So most of these devices have a measuring device that gives you the length, or you can put a second wire, as in this case, of the same length, and take a measurement, and accounting for the defect measured on the CT, you calculate and from the get the final length. If you put too long a screw, then you will not get the compression effect. If you put too short a screw, then your threads may not pass the fracture. So your screw length has to be exact. I'm going to skip the exposure part. Yeah, so this is a case where you put the odontoid screw. This fellow also had a subaxial fracture. So there are some studies regarding one screw versus two screws. Single 4 mm screw or 3.5 mm, they have the same strength. But if you can, always pass two screws. One study from India, it said in 2/3 of the cases, two screws are not possible. Post-op care is routine, immobilized the same day, is a very quick surgery. Just looking at some meta-analysis, there was a non-union rate of around 9 to 7%. These are the cutout rates of around 5%, malposition of around 5%, and you can still have loosening. The loosening is again more likely if your screw length is wrong, or if the fracture is very old and there is a large defect. People have studied navigation versus two fluoroscopes. I don't know how navigation, and there is no difference, but I would still rely on two fluoroscopes, because navigation, if your tracker moves, then you can go grossly wrong. So I would still say two fluoroscopes are far better than navigation in this particular case. As I said, if the tip is very sclerotic and very small, then you may not be able to achieve. Or if the odontoid is completely hollow, you'll have to make sure that your threads engage the posterior cortex. Otherwise, there is not going to be much hold in the hollow bone. Sometimes the C1 and C2 is already fused. So the stress on the C1, C2 is going to be very high. In that case, you can either use an anterior transarticular screw if you don't really pick it up, or sometimes you can even put 3 screws, including transarticular and the odontoid. In this case, the screw was slightly going off lateral, but the hold was good and there was a good clinical outcome, but still aimed right to be in the center. So to summarize, selection is the key. You have to make sure that the fracture pattern is correct, patient morphology is correct, and the implants are correct. Overall, this is a very elegant and a beautiful technique. It should be part of the armamentarium. Thank you. Right. Yes, sir.
Yeah, can I ask you a question? Normally, we try to get holes into the posterior superior cortex, to get a good purchasing power into the a far away fragment.
Yes,
And you specifically mentioned not to puncture the posterior cortex.
yes, sir.
There is a pons. I mean, we have been doing it often. Then I never came across. I mean, you will have to see to it that your wire doesn't migrate too far, or and you have to be a bit precise about the length. That we should always be. Well,
yeah. So as you rightly said, the length is very important. Your length has to be correct. If you're too long or too short, then it may not achieve the desired results. Yeah. Is Dr. Abumi here? Abumi sir, are you around?
I think it's my talk next.
Yes, sir. Right. Thank you, sir. Okay, we'll go move on to the next talk. Dr. Ajay sir is going to talk on computer navigation on CV instrumentation. Ganga Hospital has a beautiful the intra-op CT navigation, and we expect some beautiful pictures on this talk. On to you, sir.
Okay, thank you very much. My talk would be on computer navigation in CVJ instrumentation. I mean, you have heard about various instrumentation techniques over the course of the lecture today. I'll just give you a brief overview of what is computer navigation and how it will be useful in CVJ instrumentation. See, basically, navigation is a process of accurately ascertaining one's position in planning and following a route. We are all well used to navigation in the use of navigating a car or using a Google navigation for knowing the directions. In spine surgery, computer navigation describes a group of technologies that merge the preoperative or intraoperative images with three-dimensional visualization of surgical instruments in real time. What does it mean? Is that you have an image acquisition. It could be either a fluoro or a CT based. You have got a processing system, and then you have an intraoperative navigation system. Therefore, when you take navigation systems, there is imaging one component, which could be two-dimensional or a three-dimensional. It could be fluoro-based or a CT-based. And you have got a navigation technology, which is two-dimensional or three-dimensionally. And both are merged together to have a generations of navigation. The first generation of navigation that came was a preoperative CT-based. Therefore, you have to register during the process of operation. It used to be cumbersome. Therefore, the second and the third generation are automatic registration. And it could be either a fluoro-based, which could be either a two-dimensional or a three-dimensional, or a CT-based, which is usually a three-dimensional system. Basically, the current generation of navigation system, there is an automatic registration. How does the navigation work? You have an image acquiring system that is either the CT or the fluoro. You have a workstation. You have the patient on the operating table and a camera which uses infrared rays. Therefore, all of them should be in line. And then it will be easy for the machine to register and we know where we are operating from. This is the setup. We have an Aero CT-based navigation system. We've got a CT machine. You have the workstation, the camera. And the patient in a cervical spine, ideally it should be positioned with a Mayfield clamp because you want a rigid system. When compared to the lumbar area or the thoracic area, the cervical spine and the occipito-cervical junction is more mobile area. The chances of error being high, it would be better to position the patient on a Mayfield clamp. And once you expose, you attach a mirror or a minimally invasive refractive array, which has got the diodes which are attached. These small balls, they reflect the infrared rays. And this is fixed to a stable segment that is usually the spinous process. In the lumbar spine, you can fix it to the iliac crest. Whereas there are alternative options. Sometimes you may fix it just to the body with plaster, but however, the errors are very high. It is okay for you to know whether you have done an adequate amount of decompression, but to manage your screw, to plan your screw, the error could be significantly higher, or it is not recommended by the manufacturer. You can also fix it to the Mayfield clamp. Here also the chance of error could be there. The most important thing is that the mirror which is attached to the patient and the CT machine or the image acquiring machine, both should be in line with the navigation camera. And then only when you acquire the image, it is transferred from the image to the software and the navigation. Everything can be done quite without any problems of error or registration error. Then you do the registration process. The image is acquired by the CT scan or the image intensifier. It's transferred automatically to the workstation. Because it's an automatic registration process, that is what the advantage of intraoperative navigation is about. The navigation probe is then placed on a known anatomical landmark. Like, for example, if you're doing an open surgery, you place it on the spinous process. And it should be shown in the image that you are exactly placing at the same site. That means to say that there is no problem with the navigation. There is no error. And then you can plan to proceed on to do the procedure by planning the screw, which is it is the most common use of navigation in cervical spine surgery. You can use it to do osteotomies and things like that. You can plan your pedicle screws, entry size, trajectory, screw size and length, and you can also pass your screw under navigation. The use of navigation has been well published in the thoracic spine and the lumbar spine. But in the occipito-cervical junction, the basic problem of use of navigation is the mobility. When compared to the thoracic and the lumbar area, the occipito-cervical junction is much more mobile. Therefore, there is always a higher chances of error creeping in during the process of when you are doing the navigated guided screw insertion. There are certain tips and tricks that we should adopt to have a safer outcome. Navigation in spine, you can get the image display in multiple forms simultaneously. Basically, you get coronal and sagittal images. Therefore, even with the high riding aorta, high riding vertebral artery, you can plan your screw to miss the high riding vertebral artery and to put a par screw or a transarticular screw much more safely. Earlier, we used to use ISOC navigation, that is the fluoro-based navigation system. The problem is, as you can see, the image quality is not that clear, not that great. And whenever there is significant malformations, significant deformity, they are not very ideal situations. Whereas a CT-based navigation or even a OM-based, which is basically uses a flat panel detector. Therefore, it uses fluoro images. It rotates about 360 degrees and helps you to get a better image, is usually ideal when you go for occipito-cervical junctional navigation systems. You can use navigation to look for reconstruction, for stabilization, to plan your decompression. As the next speaker is Sachin is going to speak, you can plan your decompression of the foramen magnum to know the adequacy of decompression. You can also, the other advantage of navigation is the fact intraoperative navigation. You can scan intraoperatively again and see the adequacy of your reduction, adequacy of your fixation, accuracy of your placement of screws. Everything can be looked at. I'll go through a few of the case examples. A type 2 odontoid patient presented late. As you can see, following position when you're navigating, you can see that the position of the reduction is quite good. Why it is important? What we have noticed is that when you have stabilized this, you have done the navigation, done the instrumentation, we don't fuse them. And when the fracture unites at the period of around 1 year, we tend to remove the instrumentation off. Therefore, you can look at the adequacy of your reduction. When you are doing navigation, it's not only helps you to plan your screws, pass your screws, which can also be safely done through an open technique. It is because basically the dissection wise, the protection of the soft tissue, protection of the neurovascular structure still remains the same. Therefore, the only advantage of navigation is that you can pass your screws much more comfortably. As mentioned again, in the type 2 odontoid fractures and ankylosing spondylitis, it helps you to know whether you have achieved adequate reduction before you plan your screws and helps you to plan your screws. We have also used it in C1 burst fractures, wherein we have reconstructed the arch by passing through across the burst fracture, stabilized it, and obviated the need for occipito-cervical or C1, C2 fixation. This is a case example of a patient who came with a neuric 4 to neuric 5 myelopathy, status post foramen magnum decompression. Actually, he had deteriorated. Therefore, in this case scenario, we used navigation to plan the odontoid resection. Therefore, where you can fix the mirror. In these situations, the mirror can be fixed either to the Mayfield or, as I mentioned earlier, you can stick it to the body. It is not as accurate because here we do not need accuracy, but we have to get an idea that we have done an adequate amount of resection. As you can see, this is the post-scanning, and you can see that post-scanning that you have done an adequate amount of resection of the odontoid. And that's where the navigation can help you during an anterior surgery. And then the patient was turned over to have adequate occipital. And as you can see, the deformity is very, very complex. It helps you to plan your screws even in very narrow pedicular area. And actually, the advantage of navigation is the fact that it makes your instrumentation really much more easier. Therefore, you don't have to worry too much about planning the instrumentation, looking at the CT scan, planning it, the size of the screw. Here, everything can be done intraoperatively with very less effort. And that's where the advantage of navigation does come in. Another example is the fact that you can do intraoperative scanning to know that whether you are screw placement, whether you are achieved the reduction, whether you are reduced the joint. Everything can be done by using intraoperative navigation systems. But as I mentioned earlier, the tips and tricks are very, very important because in the cervical spine is morely mobile. It's always better to fix the DRA or the diffractive array very near to the construct. It's better to use the stable fixation point, usually the spinous process, below the area of fixation. Like, for example, you're doing occipitocervical, you can use C4 or C5. Always use power instruments so that the movement that happens at the cervical spine becomes less. You make the pilot holes. Don't try to put the screw because I marked the screw in C2 or C1. I don't go ahead and put the screw. I mark the screw in all the C1, right side, left side, C2, right side, left side, and then tend to go on to do the occipital one because the occipital condyle is relatively stable. It's fixed to the skull, less chances of intersegmental movement. Therefore, it's always important that you do your job over the cervical spine and then move to the occiput so that the chances of error. And its other much more important thing is that when you are doing navigation, keep on intermittently check the accuracy. Place the probe over a known point and see whether the accuracy is still there. If there is a doubt, you may have to rescan. To conclude, navigation is not a gimmick. It helps a lot. It makes a difficult part of the procedure, like putting screws subcortical, and makes it much, much easier for you. Therefore, you concentrate on doing the main part of the job. It has significant value to the armamentarium of spine surgeon. But as I mentioned earlier, the technical expertise, knowing how to do it freehand, always is essential, especially in occipitocervical area, where just because you know navigation, you cannot put a screw without doing adequate dissection. Protecting the neurovascular structures is very, very essential. Therefore, your expertise really matters. It is a useful adjunct, but not a substitute for your surgical skills, and probably reduces the complications, make the surgical duration much lesser. Thank you for the patient hearing.
Thank you, sir. Beautiful pictures. We'll take questions in the chat box due to lack of time.
Thank you.
It's really sad we can't take questions on these topics. Next, we'll have Dr. Sachin Borkar talk on foramen magnum decompression. We have a pre-recorded talk.
I am Dr. Sachin Borkar, and I shall be talking about foramen magnum decompression indications and technique. Foramen magnum decompression is needed in a variety of conditions. Anterior part of the foramen magnum is actually the basion, the base of the skull. The posterior margin is the opistheon. See carefully, this is the posterior aspect. It is actually the foramen magnum rim. The posterior foramen magnum decompression will cover almost 120 degree of this circle. So indications, the foremost indication is Chiari malformation, in which the cerebral tonsils are herniated into the spinal canal. The other indications are the congenital craniovertebral junction anomalies. When you are manipulating the joints, you may need to decompress the foramen magnum before you are aligning. The effective foramen magnum area for the cord is decreased in this case, so we need to do foramen magnum decompression as well, in addition to the joint manipulation. And then there are conditions like syndromes like achondroplasia, mucopolysaccharidosis, who has foramen magnum stenosis as a component without any instability. And in such cases also, when the patient is presenting with myelopathy, you may have to decompress foramen magnum. So the position is standard prone. Mild flexion is sufficient. Incision is standard midline. So I prefer an incision which is slightly above the inion. Because in Chiari malformation, you have to do a duroplasty, for which a local pericranium can be harvested if the incision is above the inion. And the lower down, it may extend up to C2 or C3. C1 and the foramen magnum rib should be adequately exposed. Regarding exposure of the C1 posterior arch, it is preferable if the tonsils are herniating till that level. And it has to be done on a low cautery setting, and you should be extremely careful beyond 1 to 1.5 centimeter on either side, because the vertebral artery will loop over the superior surface of atlas in that region. So you need to be careful there. 3 by 3 centimeter suboccipital craniotomy is done. And once that foramen magnum bony decompression is done, then you have to remove this atlanto-occipital ligament, which is a thick extradural band, cranial side, and this is the CV junction anomaly. So we already put the screws below, and this is 3 by 3 centimeter craniotomy, which we are planning using a Midas Rex MA drill. We drill the initial bone. At times, there are venous channels in this bone, and this bone is quite thick. So you have to gradually drill without, and the drill should be used like a paintbrush so that you do not injure the dura. This is what I was telling, the venous sinuses. You have to carefully irrigate, apply bone wax, and then it will stop, and then proceed with your further drilling. Remember that this bone here is quite thick and you may have to drill layer by layer. So I'm checking it with the periosteal elevator. Further clearing the soft tissue, and this is the foramen magnum, the deepest part we are taking out. This is an occipitalized atlas, so you can see that the C1 is also attached, the posterior arch, to the occiput, and this is also being drilled. Careful subperiosteal dissection first, then the drilling. And this is done on both the sides. And now it is quite mobile, so it is being held with an Alice forceps, and we are trying to remove this. You can see it now, the bony decompression has been done. Then this extradural constricting band, which I was telling, this is called the posterior atlanto-occipital membrane. This is frequently very much hypertrophied in CV junction anomaly. And this is the last bit of that extradural band. We are gradually dividing it. So we are not opening the dura, we are just dividing this band and peeling this off from the dura. You will realize that this also provides a lot of decompression to the cord. So as you can see now, if you can appreciate that you can see the tonsils moving below this dura because we have adequately decompressed. So dural opening, usually in CV junction anomaly, it's not needed, or carry malformation is the only thing for which you are doing foramen and decompression. Then you may have to open the dura and do an augmentation duraplasty along with the tonsillar shrinking or resection. The dura is usually opened in a Y-shaped manner. So this is the Y which you have to create. So the Y limbs above and the midline vertical limb below. This is a small video. We already did a 3 by 3 centimeter suboccipital craniotomy, and now this is the caudal area and this is the cranial area. And you can see we are opening the dura, the vertical midline limb, and then this is the CSF coming out. Taking the tagging sutures. Now see the adhesions between the tonsil and the cord. These are the arachnoid adhesions. We are trying to divide it by sharp dissection. This is the tonsil, fourth ventricular floor, the obex, which was plugged initially by the tonsils, and now it is opening up. You have to sharply divide this adhesions because this is what is causing tonsil not to ascend. And these are the pica, the posterior inferior cerebellar artery, and we have to be careful not to damage it. Once that is done, you may shrink the tonsil with bipolar coagulation, and if needed, you can also do a subpial tonsillar resection, as has been done in this case. So I'm using a CUSA for doing the subpial tonsillar resection, and we will do this mechanical reduction of the tonsils so that further chances of adhesion and plugging are avoided. This is done on the other side as well. You have to now close the dura and do an augmentation duraplasty so that there is more space for the cord as well as the posterior fossa. We usually take a locally harvested pericranial graft from above the inion, and then it is closed with a 4-OPDS. Avoid blood seepage dura. So to conclude, that FMD is a very useful procedure at the CV junction in a variety of conditions. Careful handling of the drill is a must, that it should be gently used without damaging the dura. And it is important to release all extradural constricting band, including the posterior atlanto-occipital membrane. Adding intradural work in carry-1 malformation with syringes is advisable. As per various studies, you can do an arachnoid adhesiolysis, tonsillar resection, augmentation duraplasty, as may be needed in a particular case. Thank you for your kind attention.
Thank you, Dr. Sachin, for the excellent talk. Can we have some very quick questions? We're running a bit late. Dr. Kshitij? Yeah.
I have one question for Dr. Abumi. Dr. Abumi is the next speaker as well. Is he there? So about this computer navigated pedicle screw insertion in the cervical spine, what do you do at your institution? I know that you are a big proponent of doing freehand screws, but you are the inventor of those screws. What do you recommend to the general people when they are going to do cervical pedicle screws? Should they be using computer navigation?
Unmute.
Sorry, you are muted.
Dr. Abumi, unmute yourself.
So we don't have computer navigation system, so I don't use it. I always do manually. But I think that sometimes I visit other hospital, big hospital, I use the navigation system, especially in the case with severe deformity. And the correction of cervical kyphosis, just kyphosis is not so difficult, just a two-dimensional deformity. But with a rotational deformity with scoliosis, I think it's very useful to use the navigation system for cervical deformities. So usually,
Thank you, Dr. Abumi. So I have another question for Dr. Sachin. It's about this controversy, right? Some surgeons say that you don't ever have to do foramen magnum decompression, and this Chiari itself is, some open the dura, some don't. What is the general consensus where people are leaning towards? Is it like just fusion? Would it be sufficient, or you really have to do the full deal? Where does your philosophy more lean in? And then we can take an opinion from Dr. Rudrappa also, who's the other neurosurgeon here.
Actually, without any manifest CV junction instability, we are just doing a foramen magnum decompression. If there is any instability which is manifest, or there is any facetal malalignment, then only means as of now we are doing the only foramen magnum decompression. But if there is instability, obviously Dr. Goyal is saying that you should fix in all cases, and actually Chiari is a sort of but there are not many studies which supports this other than his own study. So till the time we have the literature, we are also conducting a study in which we are studying it in both arms, whether decompression and fixation, in two randomized sort of study. So till the time we are getting result on that study, and we also get data from other institutes, we are going ahead with foramen magnum decompression. It's working well in our hands. And this has been quite a hotly debated topic of late, but most of the people are yet not convinced in fully shifting only to fixation and not doing decompression.
Thank you, Dr. Sachin.
Kshitij, as you asked, there is two ways of doing FMD. One is, as you said, people don't open the dura, and some people open the dura. If you look at if there is a foramen only Chiari malformation without syrinx, then doing only the craniotomy of a small around the rim is more than sufficient. But if there is a syrinx, is usually related to, we call slush and slash theory, where the CSF in the cranial content is having a higher pressure compared to the spinal canal, and through the Virchow-Robin space, the fluid enters into the spinal cord. So whenever there is a syrinx, it is always better to open foramen of Luschka and Mejendi. You had to see the flow of CSF across the cranial cavity to the spinal canal freely. And many a times I have seen a cobweb membrane at the obex. Obex is the end of the foramen of Mejendi. And unless you remove that, the CSF flow between the spinal canal and the cranial cavity will not become uniform. So ultimate aim to prevent the further progression of the syrinx is by seeing a clear flow of CSF between the cranial cavity to the spinal cavity. For that, we have to enlarge the foramen magnum, take out the bands, the soft tissue bands, and the cobweb formation around the obex. Till then, the syrinx will not improve. And many patients will come back even after the foramen magnum decompression alone, bony, after 5 to 6 years with an increase in the syrinx. So with syrinx, open the dura. Without syrinx, no need to open the dura. That's the simplest way of telling.
With this, we'll end the session. Thank you everyone for being here. It was a very exciting session. We move on to the next session based on CV junction deformities. I'll hand over the session to Dr. Umesh Srikanta. On to you, sir.
Yeah, thank you so much, Manish, Kshitij, ASSI team, and I've been given the honor of moderating this star-studded team. And in the beginning, I think let me invite Dr. Abumi, who is already ready with his talk, because we are running late of time. I'll not further delay the proceedings. Professor Abumi, over to you. He's going to be talking on realignment of CV junction deformities using an all-posterior approach. Sir, over to you.
Hello, good evening. Sapporo is now in the midwinter, so outside my home is like this. And thank you very much for this invitation. My topic is the alignment of craniovertebral junction deformity using all posterior approach. And we have many causes of the craniovertebral anomalies, deformities. Congenital anomaly, including OC assimilation, atlantaxial assimilation, also odontodium and combination. Also, inflammatory disorder, post-traumatic tumor, and other conditions make a deformity at the OC junction. Here, we have two good indicators for evaluation of the deformity. One is Wackenheim-Krivitz canal line. This is the line between the posterior surface of the crevice and the posterior margin of the dens. And the next is the CMA, cervical medullary angle. This is very useful for evaluation of radiological condition. And the normal ablation of CMA is 163 degrees. The mostly cause of the combined deformity of flexion at OC1, C2, anterior translation of C1 or C2, and vertical flexion of subluxation of the dens called the basilar invagination may cause compression of spinal cords at the anterior aspect. So anterior aspect of nerve is compressed. So we need anterior decompression for this condition. So the direct anterior decompression includes transoral approach or mandibular splitting approach. Dr. Alan Crocker from England, he likes anterior approach very well. And we sometimes discussed for the indication. But disadvantage of direct anterior decompression includes insufficient bed for bone graft, difficult internal fixation, and requiring additional posterior fixation. No. So this figure shows the reaction of the OC junction deformity. Now we put the plate or knot on the occipital bone and connect with the screw insert into the cervical pedicle, usually in C2. If we tighten the nut, and the relation between rod and plate and screw becomes perpendicular. And this cause provide extensional force and the distortion force. So we can expect the correction of flexion deformity and vertical stabilization by extensional force. If we need, further reduction of vertical stabilization can be obtained by application of destructive force if we need. We published this concept in 1999 on Journal Spine. Yeah, this is one case I did in Kathmandu, Nepal, almost 10 years ago. This patient has odontodon. The motion is very small at OC1, C2, but very rigid, but little bit of motion we can expect, we can see. So I thought must be reducible. So I did two screw into the C2 and two screw into the C3, bigger screw, and correct the deformity like this. We can get a good reduction and good improvement of nerve disturbance. This is a recent my case. This patient had a congenital anomaly, including with hospital C1 assimilation, OC2 and C3 T1 union. Yeah, motion at OC junction is very small, but you can see this patient had a joint at C1, C2. Joint C1, C2. So this must be reduced result. So but this patient had some congenital anomaly at vertebral artery and abnormal condition of C1, C2. Here you can see C1 is fused to occipital bone. So screw insertion is not so easy. So you can, this is a real video, intraoperative video like this. I always sit at the cranial portion of the patient. So this is the occipital bone fused with C1. This is a C2, C3 segment. So I'm looking for insertion point of C2 pedicle screw. This is a fused C2 and C3 lamina. They are very unstable at C2, C1, C2. So make a screw insertion hole and put the probe like this and insert the top and the screw. Sometimes C2 screw can penetrate the anterior of the C2 vertebral body. And then this is a C2 screw, bigger screw. But the right side, I skip the C2 bigger screw because of the abnormal condition of the vertebral artery. I insert only C3 from the outside. I'm taking a bone from the C2 and C3 area. And put the plate and bend the rods, expecting a reduction. And multi screw, at least 3 screws must be inserted. And after the tightening of the nut, we can expect reduction. And this is the bone from the area. No. So this is the result. You can see good reduction. You can see the good reduction about the deformity of the nerve like this. So this patient had a good improvement of the nerve function. Yeah, this is the case of rheumatoid arthritis. Yeah, this is a severe deformity of vaginal invagination and flexion deformity. Flexion deformity was not so severe. We insert the screw to C2 and reduce it. Yeah, this is the result of radical result of the vaginal invagination. The preoperatively, patient had 3.3 millimeter from the mercury line and tip of bottom of the back. This increase 4 millimeter. So we got 7 millimeter reduction of vaginal invagination. This is OC2 angle. OC2 angle improved almost 10 degrees pre and post operative like this. So this is the cervical midline angle, pre and post operatively. We got 20 degrees of improvement of CM angle. Also, you can see, you can see good result of CM angle like this. You can see the improvement of correction of vaginal invagination and flexion deformity and atlant dislocation on axials. Some doctors are worried about the anterior support, but you can see that in this case, you can see joint space has improved, large. But axial loads, the preoperatively shifted anterior of the spine, but after the surgery, after the correction of the deformity, axial load transferred to the posteriorly. So most of the axial load from the skull, the grafted bone and the implants can support. So we don't need bone graft into the OC or the Atlantic exchange joint. But sometimes patient had a reducible deformity like this. This is a case from the Professor Wang from Beijing University Third Hospital. He did a very good anterior release. This is a case with a severe craniovertebral junction anomaly like this. This is the small patients. Before surgery, they release anterior by anterior approach. And after anterior release, they do skull traction and posterior fixation by using instrumentation like this. They got a good reduction for this patient. But this type of the case is not so often. I'd like to say regarding the occipital anchor, multiple screws near the midline must be required. Bicortical purchase is recommended. The bicortical purchase is much stronger than unicortical. But in the craniocervical function, if patient had, especially in the congenital deformity, patient sometimes had abnormal condition of vertebral artery like this. We have to be careful. So preoperative evaluation of vertebral artery condition by MR angiography or CT angiography. Sometimes patients have abnormal condition of risk circle like this. In this case, the one side of a posterior communicating artery was locked. So sometimes if we injure the vertebral artery both sides, really disaster for this condition. If patient had only one side vertebral artery, usually harmless to the brain. But if we injured bilaterally, so in some case, it's a terrible condition too. Like this. This is very risky for the two-sided vertebral artery injury. This is not a surgical case. In this case, this patient had rheumatoid arthritis and a very severe condition at OC junction. In the preoperatively, we tried angiography like this. If we applied, patient applied extensional force, one side of the vertebral artery was occluded. This is terrible. So we stopped the surgery for this patient. We need spinal cord neuromonitoring, and the vertebral artery can be monitored by intraoperative confirmation of vertebral artery flow using ultrasound Doppler. Ultrasound Doppler is very useful to hear the vertebral artery flow to intraoperative. Yeah, this is a case of salvage surgery voicing junctions. Yeah, this is the Doppler system, ultrasound Doppler system. Can you see the sound of Doppler vertebral artery flow? We can see the location of vertebral artery. And also we can see the flow of the vertebral artery. Yes. In conclusion, I'd like to say correction of deformity as a craniovertebral junction provides sufficient neurological improvement. Most of the craniovertebral junction deformity can be reduced by single posterior approach. Screw inserted into the C2 and subaxial pedicles are useful fixation anchor for craniovertebral reconstruction. We also report this concept many years ago, 1999, on Janus spine. So I'd like to say indirect decompression by deformity correction at the craniovertebral junction provide good reconstruction, good neurological improvement. In many cases, we don't need direct anterior decompression. Thank you for your attention.
Thank you so much, Professor Abumi, for that crisp and detailed, talk. It was very informative. We have a question from Dr. Kshitij. Dr. Kshitij, you want to put across the question to Professor Abumi?
Yes.
Yeah. So these are those special screws that have a particular design. Those screws are not always like, we don't have those kind of screws. So is there any alternative we can use? Like say a monoaxial reduction screw, which will work the same way?
I think monoaxial is much better than polyaxial for correction, but the company don't like to use make the monoaxial screw. So recently I used polyaxial screw, but polyaxial is also acceptable to use for reduction.
So the same thing will work with polyaxial also?
Polyaxial is also not same. Monoaxial is much stronger than polyaxial.
Much stronger. But we don't have those screws.
Yeah, Professor Abumi, so we are going to listen from Dr. Sharath following this that, he's going to put a cage in the C1, C2 and achieve the same reduction for all these things. So what is your concept about this? Because we saw in most of your cases that you don't distract the C1, C2 joint. So what is the difference? What is the difference between, the two techniques? So how would you say whether a cage is required in which particular case and when is it not required?
Yeah, talking about the cage?
Yes, please.
The C1, C2 joint?
Yes.
No, I don't use the cage. But after reduction, after correction of the deformity, and the axial load moved to the posterior. So anterior support is not so important. So, and grafted bone in the posterior and also implant in the posterior, that supports the axial load. So I think in the most of the case, we don't need anterior support after reduction.
Okay, all right. So I think we'll take one last question from Dr. Ashok, and I think we'll move on to the next talk. Please, Dr. Ashok, yeah.
Yeah, Professor Abumi, a nice talk. We use a different technique, which I'll be showing it later, where we use an under-contour plate, which is more like in a cobra shape, a little away from the occiput. So we first fix the C1 and C2 with an under-contour plate. We press that C2 other plate onto the occiput, so that automatically pushes almost the same mechanism onto the as anteriorly as possible under the basium.
So firstly, you put the screw, correct the tighter screw, and the next step to push the
plate the plate onto the occiput, so that indirectly pushes the C2 more anteriorly.
I think that also we can get the same result. Thank you.
Yep.
Umesh, I have one question and kind of a different concept. Is
please.
The wonderful presentation. The atlantaxial dislocation and basilar invagination pathology is changing its concept that it is now the whole pathology happens at C1, C2 level, and we are unnecessarily adding the occiput as an additional anchor. So especially with the modern day, where one movement of the head should be available to the patient, because with the C1, C2, we prevent the rotation. Flexion extension also will prevent with occipital involvement. So many of us are using the C1, C2 cage and everything to prevent the additional occipital anchoring and reduce at C1, C2 level. That's why now many, including the spondyloptosis, are treated at C1, C2 level, preserving the occiput and occipito-C1 junction as an intact one. And your comment, I would love to listen to that.
Okay. I think in the most of the case, I do only C1, C2 fixation. My case of fixation is not very limited. So if C1 is sometimes fused or almost no motion at OC1. So sacrifice of OC1 joint is not so important, not so harmful for the patient. So in the case, if C1 is fused to the occipital bone or almost no motion, the preservation of the C1 OC1 joint is not so important. And the next, most of the patient is old, more than about 50 or 60 degrees in Japan. So OC1 fixation and C1C2, OC2 fixation and C1C2 fixation is not so different, I think. So, and I'd like to say, C2 screw fixation provides very strong anchor. So I think it is very good for reduction.
Okay, because we treat mainly congenital compared to what you do in the West, rheumatoid and ankylosing spondylosis. So I think that will be the difference.
Yeah, thank you so much. Thank you so much, sir. I think because of lack of time, we'll move on to the next talk. It gives me great honor to welcome and introduce Professor Sarath Chandra. You know, he doesn't require an introduction per se. So, sir, please, over to you. He's going to be talking on his brainchild, evolution, the concept and technique of DCR. Sir, over to you.
Am I audible?
Yes, you're all loud and clear.
Told my video is already there. So in case it's not there, I'll play from my end.
Sir, you can play it at your end.
Okay, just give me a minute. Just a minute. Because I was hoping it would.
Yeah, so until then, I think Dr. Sachin has a question. So in the case of an occipitalized C1, if the C1 lateral mass is good enough, if there is a good space and the vertebral artery is not in the way, so would anybody, or what is the take on of the panel of putting a C1 lateral mass screw rather than going and fixing it with an occipital plate? Professor Abuni.
It is accepted.
Yeah, yes. So, but how many times, or what are the how many times would you be able to do that? Will we be able to do it in many cases, or it's only a small percentage?
No. Very few patients will have that, the C1 condyle submerging with the occipital condyle. Actually, in fact, in such patients, the size of the C1 lateral mass is bigger than normally what you find.
Yes,
it's very good, and you can get a beautiful bicortical purchase.
Yeah. Thank you so much, sir. I think Dr. Sharath is ready with his presentation. Sir, over to you.
So thank you very much for this opportunity. I'll just play video of two very severe basilar invaginations, because we deal with extremely complex cases. And these are the cases I believe you cannot tackle it until you apply the technology of DCR. So let me just play the videos. It has an audio. The case history of the patient. Is the audio audible?
Yes.
Section and extension view. CT scan with cerebral reconstruction. 3D CT with angiogram. MRI is showing severe compression. This slide briefly explains the concept of pseudojoint. So the surgery which was done was a DCR technique, which stands for distraction, compression, extension, and reduction, where the spacers are used as pivots to reduce both the atlantaxial dislocation and the residual basilar invagination.
PCR is indicated in cases which are congenital, where the C1 is hospitalized, especially those associated with severe basilar invagination and atlantoaxial dislocation. We prefer a 3-point fixation, which includes occiput, C2 or C3, and C3 or C4. These are some of our brief publications. DCR makes a plumb line correction, as it can be seen here. We even demonstrated in our studies. Surgery is performed with patient prone on horseshoe. Generally, I don't prefer a traction, but if at all traction is required, we can place the patient in a Gardner's traction, more for stabilization rather than for the use of traction with perhaps 2 kilograms of weight. We perform a standard exposure from occiput to C4. The following video shows exposure of the left joint, where we are drilling a bit of C1 arch to create more space, and we are exposing the left C2 ganglion. In this case, we were able to preserve the C2 ganglion, and this shows exposure of the left side joint. Now we are exposing the right side. We are now performing the foramen magnum drilling. In this case, it can be seen that the foramen magnum was very deep, and we drill about 2 to 2.5 centimeters. It's important to also remove the fibrotic bands to release the cord posteriorly adequately. Here I'm showing the exposure of the right side joint. As you can see, I prefer using a variable impedance bipolar, especially from Sutter, which allows me to very nicely and adequately coagulate all the venous plexus. So it's very important for us to disarticulate the joints completely. So here we're disarticulating the joint on the left side, and in this case, I prefer to use a periosteal elevator and turn it right angle. And following this, we do joint remodeling and denuding the articular cartilage using a diamond drill. Once the joint is ready, we are introducing the spacer. So since the basilar invagination and AAD is very severe here, I start off with a spacer which is 11 millimeters on the left side and 10 millimeters on the right side to allow me correction, which is on the coronal sections. So these are the special spacers which have been designed by us, which are biconvex spacers, which allow the spacers to be converted into pivots while performing the technique of DCR. So now both the spacers are in C2. Here we make place lateral mass screws in C3 and C2 power screw, so as to allow us to provide C3 3-point fixation. The following diagram shows the universal reducer, which we are developing in collaboration with Medtronics. It consists of a reduction system, which has a C2 translator system, as well as a cable wire reduction, which is made of braided stainless steel, which is much more stronger than the usual titanium cable. And it is attached to a special tensioner device. In this case, we have used only a wire compression, as the posterior listhesis of C2 was not significant. So in this technique, we are first placing a temporary occipital plate. In this case, I prefer to place 2 occipital plates in order to provide me a long length traction for the wire. Now we take the specially prepared braided stainless steel cable, which is glued around the C2 spine and then passed along the holes of the occipital plates. Now this is then passed to a provisional crimp, and now we use the special cable tensioner. So when we tighten the cable, this leads to compression, that is very good impaction between OC1 and C2, and the spaces get impacted very nicely. Continued compression leads to extension at the OC1 and C2 joint, as it can be seen here. So here the spacers, both the spacers, they act like pivots, leading to a complete reduction of basilar invagination and AAD. The specially designed nature of the spacers allow adequate reduction. Now, in this case, using 10 and 11 millimeter spacers, we were not able to achieve enough reduction, which was expected. But I always start off with the smaller size spacers and then slowly increase the height of the spacers. So now I remove the earlier spacers, and now I'm using the final size spacers, which are 18 millimeters on the left side and 16 millimeters on the right side. Generally, the large size spacers are very difficult to introduce, so I use a special railroading technique using the periosteal elevator. So we have to understand that increasing the height of spacer provides us the additional lever advantage. So in case we are not able to achieve optimum reduction, by increasing the height of spacers, we will be able to provide that additional advantage, which will allow us to reduce both the AAD and BI satisfactorily. So the left spacer is now in C2, and now we are introducing the right side spacer. And you can see how their spacers are hammered inside. And now we repeat the cable compression again as shown earlier. And this again, you can see will lead to movements of compression followed by extension at the OC1 joints. And this time we have achieved adequate reduction, as it can be seen on the OM image. Also note the adequate correction of cervical hyperlordosis. Now you can compare this with pre-op scans, and there has been a very good and a significant reduction. At this point, we fashion the rods in order to perform the standard 3-point fixation, which includes an occipital cervical fixation. Placing adequate bone graft mixed with hydroxyapatite ensures good bone effusion. Post-operative CT scan shows very good reduction. This is another short example just to show the use of a C2 translator. So this is an 8-year-old boy with severe spastic quadriparesis, short neck. And in this case, you can see that there was a severe basilar invagination, AAD, presence of a pseudo joint, and there is also a backward movement or a listhesis of C2, which leads to severe angulation of the dens backwards. So the patient also had a posterior fossa dermoid, and we reported such rare instances in neurosurgery way back. So we have to understand that when the basilar invagination and AAD becomes severe, there is also an additional motion of backward listhesis of C2 over OC1. And in such cases, we prefer to use the C2 translator. So we place the standard occipital plate. The spaces are already in C2. In this case, you can see we're providing a special C2 clamp, which I generally prefer using it in pediatric patients in order to prevent the Y from slipping. And now we place the C2 translator with the pivot on the occipital plate. A screw is now passed through the hole. And now we can see that we are providing simultaneous movement reduction with the cable tensioner as well as the screwdriver. So the cable tensioner provides compression and extension, whereas the screwdriver here pushes the C2 forward, leading us to a very optimal reduction of the listhesis between OC1 and C2. This is a 3D OM image. And we have designed the special spacers which could be connected to a rod by a connecting rod, which we have placed in this case, and you can see it's a very satisfactory reduction. The dermoid was also removed in the same setting. Both patients improved in the spasticity and power and were walking at 3 months. Thank you very much.
So
thank you so much, Dr. Sharath. Thank you so much. Any questions? Any questions if any faculty wants or delegates want to put across to Professor Sharath? So meanwhile, Professor Sharath, I'll start off with the questionnaire. So in many cases, we see that once we put in the cage in, the reduction or the extension maneuver that we do on C2 becomes more and more tougher, more and more difficult. And the bigger the cage, the more difficult is this maneuver. So what are your tips? Of course, you use a cable graft in order to pull the C2 up, but sometimes we have noticed that even with that, it is difficult to reduce the AAD after we have put in the cage. But without the cage, it reduces nicely. So what are your tips and tricks in such situations?
So excellent question. I'm so happy you asked it. So now I compare my technique with cervical arthroplasty. The most important part of the surgery is preparing the joints. It's very important that you completely disarticulate the joints. For that purpose, you have to do complete dissection. You have to put periosteally elevators simultaneously in both the joints and then turn them around. So by the time you're placing the screw, both the joints have to be totally loose. So if you see, most of my procedure, 80-90% of the joint procedure is only disarticulating the joint. Now, after that, once you put the spacer and reduce it, it's over in just a couple of minutes. It doesn't take much time at all. So that is the key. You need to disarticulate the joints completely till they are loose, and that takes some time. That really takes some time. And you can do it bloodlessly. There is absolutely no blood. You just need to know how to do it properly.
Yeah. So there's a question, one more question. Thank you so much for answering that. There's a question by Dr. Kshitij. Do you want to put it across, Kshitij? Or
So yeah, why can't we do like the joint disarticulation? First, do the universal reduction device before putting in the cage. Is that primarily to get the vertical reduction, or let's say, can that be replaced by putting the patient in traction after the joint release and then do the cage?
Okay. So that's again a very good question. So you have to understand, if you don't put in the cage, when you use the cable compression, it's going to further exaggerate the basilar invagination. The reason basilar invagination gets corrected is you put a cage there which acts like a pivot. It's very similar to Archimedes trying to lift the earth when you put a pebble and then use that rod in order to lift the globe. So you put the spacer there and then you start compression. Then you find that there is a movement in the opposite direction on the other side of the pivot, which leads to a very optimal reduction of basilar invagination. And not only basilar invagination, it also reduces the residual atlantoaxial dislocation. So putting the cage not only reduces basilar invagination, it reduces the atlantoaxial dislocation also. The only thing which cannot be reduced is the backward translation. So that is found in a very, very severe cases of craniovertebral junction anomalies, where there is a retrolisthesis. So even if you correct, there still will be retrolisthesis of the C2 over C1 or OC1. And that's the reason we have introduced the concept of C2 translator, where you put a screw and then you push the C2 forward. So if you don't have a C2 translator, even if you try to push with your hands the C2 quite a lot, you'll be able to correct it. So that additional element of translation in a horizontal direction was introduced by us. So this concept of retrolisthesis, which is present between OC1 and C2, has been for the first time described by us. Otherwise, it was not known. People used to think that it's only distraction which has to be corrected. So there's one more question. Maybe I could read it if you don't mind. So
yes, please.
How do you compare your technique versus anterior retropharyngeal release followed by posterior fixation? So I have never done an anterior retropharyngeal release. I have absolutely no criticism to those techniques. I believe that each of these techniques have their own value. For instance, the technique described by Dr. Patkar, which is a ventral procedure, you do, that's excellent. But for basilar invaginations like the ones I've shown you, there is no other technique which is going to work. That's the reason I've shown such extreme cases. You need to release the joints. You need to put a spacer of an optimal height. You need to correct it. That's the reason I've shown such extreme cases. They'll work fine. If you have minor basilar invagination, AAD, they'll work fine. But once it goes to beyond a certain limit, you just cannot do it with any other technique except through this technique, what we have described.
I completely agree.
Thank you so much.
Umesh, I completely agree with Sharat's this thing, because basilar invagination, the way he showed that cases, the translation of the C2 which happens with the cage fixing in, whatever we push from the posteriorly, the C2, it will not come unless you have something distractor between C2 and occiput. That's what is a DCR technique which does. I used to do it anteriorly, capsule release, anteriorly go in, put the reamers and open it, and then go posteriorly. Ultimately, in AAD and the listhesis of the lumbar spine and spondyloptosis is release. Joint has to be released. After releasing, you have to keep some fulcrum in the anteriorly to pull it backwards. I think, Sharat's technique is wonderful only when the basilar invagination of that high degree with congenital anomalies. As he said, anything less than that. can also be useful without doing that.
That's right, Satish. It's you can do it with any degree of basilar invagination. But the thing is, yes, if it is a mild basilar, you could do it anteriorly also, you could do it through a release also. But the advantage is if you stick to this one technique, I have never done any other technique, but I have been confidently been able to reduce, and more, I've done more than 350 cases and more than 1000 cases of CV junction. So more I do these techniques, more you start learning about it, more confident you get. There's a grading, it's a spectrum. You start with the simple cases, and then you keep on going through the complex cases. And when you keep on doing it, you keep on getting more and more convinced about it.
The problem with this is that the size of the cage which you are mentioning, that height is not available commercially.
It's available in the one, it's available in the one which you have designed, and that's now available commercially. So
because the maximum I have used is about 8 to 10 millimeter.
So that's another thing, Satish. A lot of people had a lot of concern that if you put such high spaces, would it lead to any stretching of the cord? Now we did a study.
No, it will not.
We did a study of MEPs in more than 50 patients. We found that even when we put it 20 millimeter size of spaces, the MEPs actually improved. So the only thing is you have to do it in a graded manner. You have to do it in a manner by which you disarticulate completely. And if it is a very severe basilar, don't go for complete correction at one step. You could do it in a graded start with smaller size cages and slowly grade it up, or slowly jack it up to higher sizes spacers.
It is exactly like spondyloptosis of the lumbar spine. Bilateral, simultaneous, symmetrical reduction has to be achieved. If you do only unilaterally, it creates a problem. So bilaterally symmetrical, reduces these kind of spondyloptosis.
Yeah, thank you so much, sir. I understand that it's a very wonderful discussion and we would like to discuss more, but for want of time, let's move on to the next topic. Thank you so much, Dr. Sharath. Next topic is by Dr. Satish Rudrappa. So, sir, he is going to be talking on revision and of failed CV junction fixations. Over to you, Dr. Satish. Dr. Satish, you can unmute here, please.
Yeah, can you see the slides? Can you see the slides?
Yeah, slides are visible. Go ahead.
Thank you. So, as we have seen the beautiful discussion by Professor Abumi and Sharath, there's a wonderful case presentations, and by doing more and more cases, you will also see many cases where you had to revise or somebody else has done. You had to, your own cases or somebody else's cases to be revision. Why the revision happens in CV junction and what are the problems I'll be discussing in this presentation. The principle of CVJ junction surgery is always the fourfolded. One is we have to get the fantastic reduction of the joint. And with joint reduction, we get the adequate decompression, which can be direct or indirect. And once we do the reduction and decompression, we had to stabilize the joint. Especially after stabilization, you had to get the bony fusion to sustain it for the longer time. So if any of these principles is failed, whether reduction is lesser, or you are not decompressed it enough, either by direct or indirect way, or you are not provided the stable fixation after the first two steps, or your bony fusion has not happened, it can create a failed principle of, the failed principles leads to failures in CVJ. So any patient with the failed one will always come back with initial improvement in his neurological status worsening the myelopathy. And, it is mainly due to, once again, the canal compromise, the lack of decompression. So the lack of decompression, once again, you can assess whether it's a mobile the mobility still persists or it is still immobile. So if it is immobile, that means you already put the bone graft, or a plating, which has fused very well, but there is an anterior compression, there is a bony fusion, then you can do direct compression like, either a C1 arch excision or odontectomy can do. But if there is a mobility in spite of your implant and the bone, which is pseudo-orthosis, there is an implant failure, then once again, you can redo the whole step from posteriorly, either by doing the indirect decompression plus grafting in these patients. So redo fixation is the key in these patients. So the problem of redo is manifold. So it is very easy to say we can redo the things. The problem starts from the exposure point of view. So the exposure will be a lot of scarring of the muscle and the venous structures. You will not be knowing the plane in which you are entering. Sometimes the bone graft is so big, it would have healed in multiple directions. Exposure becomes very difficult. And the dura vertebral artery injuries are very common. Always better to use IONM and Doppler in these patients because the anatomy becomes haywire. The loss of anatomical landmark once again, because the bony fusions, whatever the bone graft you have put in, can also relate to anatomical landmark loss. Always use the navigation. And if there is a difficult, implant removal is also key, especially when the cage is abnormally placed and cage is coming backward and is already partially fused because the tooth holding anteriorly. You cannot remove it very well. And sometimes the distraction also will not be enough in these patients. So the larger or additional screw or alternate technique you have to know. And whenever there's a bone mass formation, you have to use the bone scalpel or blurring to be done. And there are a lot of times there'll be CSF leak or wound dehiscence in these patients. Proper closure is mandatory. So these are the problem. We always face it. So always make sure you use the microscope, use every technology available to you, and get well versed with all the equipment which is there with you in this patient. The common causes of failure is poor joint preparation. As the previous speaker said, joint. How much you prepare well, how much you align it, how much you distract it, how much you reduce it is the key to prevent the failure. So you had to get the good alignment before grafting. So good alignment and grafting is mandatory to prevent the failure. Fixation done with the C1 arch removal is practiced widely, but do not do it as far as possible, because as shown by Sharath, as shown by many people, that you can use the C1 as another anchor, using the cable construct or anything, you can pull it back, joint alignment become very good. And also it adds the additional surface for bony fusion. Do not remove the C1 arch unless really required. And also removing the C1 arch give the pseudo feeling that the spinal cord is, the canal is widened, but it's actually pseudo feeling because the pressure is more anterior in most of these atlantoaxial dislocation or AADs. And occipital C3 fixations are done without, sometime without using the C1 as an anchor. That is also one of the problem, because the C1 continue to fall forward. The C2 continuously come backward when you have occipital C2 fixation without an anchoring C1 in some way, either posterior way or anterior lateral mass fixation is mandatory to prevent the failure. Inadequate bony preparation, as Professor told, that you had to take out all the soft tissue, drill, get the bony bleeding, and then use enough of iliac graft to get the good fusion. Ultimately, fusion is important. And all of these factors leads, if not done well, leads to pseudoarthrosis and poor anchoring and causes the failure. The first surgery is always the best surgery. Second surgery is always, there is a second surgery in CV junction. So how do you plan, whether anterior or posterior? So once again, you have to redo all your imaging techniques, CT, MR, radiograph, angiogram in these patients to understand the real anatomy, because this, the redo things will be much more worse than the initial one. And also get the dynamic radiograph, both CT, X-ray, as well as MRI to see any compression anteriorly and also the bony anatomy, how you can look in and prepare a three-dimensional bony modules so that you will understand better. And as I mentioned, if it is an immobile AAD, use the traction, see whether it's moving, or if it's moving, do the posterior approach once again. Or if it's not moving, then you can do transoral approach or C1 arch removal, you can do it. If it's a mobile AAD, posterior approaches, redo the whole thing, it is doable in these patients. So you can see whenever you do the redo, all these approaches, you should be versatile. Be versatile with the Goel technique and Harm technique, transarticular technique, even the Harm's technique, and also the transarticular bilateral technique. You had to be versatile. You should have done enough of these cases before you accept the failed aid, CV junction patients in your surgical practice. So I will show you a few cases here. Here is a 67-year-old lady, school teacher. She was operated elsewhere where they have done a beautiful fusion, simple with a wire technique with occiput to C2, and a large bone graft was done. And you can see in the CT, it is completely fused posteriorly. So beautifully fused, you rarely get this kind of a fusion in these patients. Patient was doing very well for 2 years, and later on started having a myelopathy, and she was wheelchair bound. So what do you do in this patient? The dynamic picture shows no mobility, and CT shows complete bony fusion. And to do the MRI, you had to take out the wire to see the component, how much compression on the cord. So clearly see, once we removed the wire, it is a simple technique, opened a small one, cut it and removed it, did an MRI, which shows a significant compression at cervical medullary junction. There is a persistent myelomalacia in this patient. There is a basilar invagination also persists in this patient. So here it is a stable fusion, but there is a compression persists. In this patient, a beautiful transoral odontoidectomy, is a simple, best way for that patient, and most of these patients do well. See, this is the patient preoperatively on the left side, and I did a transoral excision. Rarely we do transoral excision in the present day, but this is the classical case where you can do, and the patient started doing even a treadmill by herself. So that is the beauty in which how to decide surgery for these patients. Here is yet another patient. Here, the surgeon has completely missed the biomechanics of the CV junction pathology. He has learned in a cadaver lab how to put the cage, and he has unilaterally fused without putting any thought process of reduction. Here, one cage has been put in without reduction, and this patient came back once again with a myelopathy. Here, if you see, the MRI shows the persistent, and also they've done transoral excision in this patient. So they put posteriorly one cage, and transorally, instead of removing the odontoid, he has removed the inferior part of the clipple fill anomaly of C2, thinking that it has reduced. In fact, patient worsened postoperatively. She was all right for 2 months, worsened posteriorly. And in such patients, here completely, it is a biomechanics problem, adequate training of the surgeon. And here you can see when we put the traction, absolutely no reduction at all. And what we have wanted, the patient didn't want one more posterior surgery. Then we had to literally convince them that, the pathology is still anterior. And first I did once again transoral procedure and removed the whole posterior and anterior odontoidectomy is done. And posteriorly, we refixed, a patient, and patient started walking from the wheelchair to able to do all the activity. This is yet another patient, cervical myelopathy with a basilar invagination. Once again, here you can see the amount of screw which is used. Here the laminar screw is used and occipital plate is used without reducing the AD at all in this patient. And the joint is still remaining, joint is aligned, but however, the basilar invagination is significant in this patient. And this patient, we had to redo the whole procedure where, we did the Goel procedure, and patient did very well because the alignment of the C1, C2 joint very well in these patients. So we have, in the present day, as I mentioned, transoral surgery has become rarity. We have published a paper where exactly we had to do the, transoral procedure, and one knowing this procedure is mandatory to do, whenever there is a redo procedures. And here is yet another patient, similarly, this is by Sushil Patkar, who keeps telling that most of these things can be done anteriorly. But, any patients where there is a posterior mass is involved and a severe basilar invagination, only anterior is a difficult procedure. And most of the cases which can be doable are the one which can be reducible even from the posterior approach. I still think extrapharyngeal approaches are useful in mild to moderate basilar invaginations, but the severe invagination requires the circumferential approach or completely posterior jacking technique, Goel technique, or DCR technique of Sharath. So here's another patient where patient was operated long ago, nearly about 15 years ago by me itself, where we did a transoral, oral procedure, and the patient had a posterior fusion, but came back with a secondary invagination because the posterior rod constructs, which we used to use contour rod, will never have that slides over a period of days. But you can see here the bone graft is so well fused but there is a secondary invasion. The residual body, it just slides upwards. In such patients, once again, we had to remove the implant posteriorly. We did the MRI, which shows persistent CV junction pathology at craniovertebral junction. And here we did, though there is a stable posterior fixation, mobility is seen post removal, and we had to do posterior fixation with one anterior endarterectomy. In this patient, I did transferal operation, surgery followed by occipitocervical fusion, and we jacked the whole thing between C2 and the occiput in this position, so that there's a wide gap available, and patient recovered completely in this patient. Here is yet another patient where the AAD with a myelopathy. Here is done by somebody else. Once again, the cage is so small. The cage, is one of the doctors. This is operated elsewhere where the Goel technique is used, but the cage is so small, it has not jacked up the joint. Joint has not come back. There is a persistent myelopathy in this patient. This patient is still thinking whether to undergo our surgery or not. The opposite side, they have not put a cage or the plate. Only one side there is a cage in this patient. Here is another patient where there is a atlantaxial dislocation with where there is a compression at C1 C2 level. And here I thought there is a good reduction in flexion extension MRI. We thought we'll put a transarticular screw fixation, cable grafting, and I did the transarticular screw fixation, Sontag technique, and patient did very well for about 1 year. A year later, came back to me with a worsening myelopathy, and the 62-year-old gentleman. And when I repeated this CT scan, you can clearly see I failed completely by doing one. Here, the joint is not, we have not used the lag screw. Second, the cable which has been used, we put a graft, the graft got resorbed. When the graft resorbs, the whole thing collapses further, and the cable by itself is acting as a compressive element. In this patient, is yet to be operated. In this patient, I had to redo the whole procedure with taking out the transarticular screw and a cable, and we had to redo with either the Goel technique or the Harm's cage technique. So in this way, multiple things, your own patient or somebody else's patient can come in. Knowing all techniques in the CV junction is mandatory. So the take-home message is, first surgery is the best surgery in CVJ. Make sure your understanding of the anatomy very well in these patients. Do all the CT scans, understand the anatomy very well, and get to know all the surgeries principles and adapt to that. Joint reduction is mandatory and a paramount. Knowledge about the anti-transfer surgery is also important in these patients. Beware of various fixation technique. C1 arch excision rarely needed if joint is reduced. Meticulous exposure of venous sinusoids is important. IO and Doppler probe navigation helps in revision surgeries. Thank you very much.
Thank you so much, Dr. Satish. Thank you so much for that wonderful talk. I think due to lack of time, we'll just take either one comment or question if anybody is willing to take that. Yes, Professor Sharath. Yeah, please.
Satish, excellent presentation. I've got only 2 comments. First of all, I think it's very important to dissipate the message that you cannot do fixation without adequate reduction.
Right.
I now have more than 70 to 80 cases. I have to exactly see, but close to 80 cases where people have just done in situ fixations and then referred them to the higher center.
Correct.
So there has to be a message which has to be conveyed that please do not touch these cases until you are confident of reducing it and putting an implant. That's the message which I wanted to deliver.
I completely agree.
And second thing is, Satish, I agree. I have never put a traction for the past almost 15 to 16, 17 years. So I don't think there is any role of traction as of now. You can easily make out the only irreducible AD which I feel is when there is a bone fusion.
Correct.
In those cases also, if there is a joint fusion, we can release the joints. The ventral fusion is the only thing which will need a transoral procedure. But we have totally stopped putting tractions.
No, I agree with you. I do rarely use it, but I use it for 2 reasons. One, to understand myself, is there still any movement persist? As I showed you the first case where the elderly lady, there's a big bony fusion which has happened perfectly posteriorly. And if there is a small movement, I cannot do transferal surgery. I have to go back, take out that complete bone and redo the whole thing. If there is no movement, still we can get away in some patient, elderly people, patients with a pulmonary problem, just a simple transversal surgery. Transversal surgery is a simple surgery according to me. Straight extradural pathology. In such patient, I will not produce further instability in such patients. That is the only reason I use, and I use it only for few hours, less than 24 hours. After that, 100% I'll never use it. Just for my confirmation.
Yeah. Thank you so much. Thank you so much for that clarification. So let's move on to the next topic. The next topic, Dr. Ashok Rathod is here. So he's going to give us a different perspective and from an anterior point of view, he's going to talk about the role of anterior release in CV junction surgeries. Dr. Ashok, over to you.
Yeah. Can I share the screen?
Yeah, please start, Dr. Ashok. It's over to you.
Yeah.
Please start.
Oh.
Dr. Ashok, we can't still see your screen.
Yeah.
Okay.
Can you see the screen? Yeah.
Not yet. Okay, it is visible now. Yes.
Okay. Okay, shall I start? Yeah. You can hear my voice?
Yeah, clearly.
Yeah,
Please
sure.
go ahead.
Okay.
Please go ahead.
Yeah. Yeah, so my topic is Wang's transferal release, and what I'm going to talk today is basically in a fixed AEDs. I think we have been talking since last half an hour. So let me just run through the basic anatomy of CV junction. This is C2, and you have C1 sitting over C2, and this is the C1 C2 joint there, and you have a beautiful funnel-shaped cervical medullary cord there. In a fixed AED, usually a variant of clipal field where you have C2 and C3 fused, and you have an occipitalized at last, and there is a great lot of mobility between this upper complex and the lower fused complex, and the whole of the C2 dome gets attenuated. There, as you can see it here, the C1 C2 joint, which is supposed to be on top of C2, now goes on to the anteriorly. So when you take the X-ray here, what we see here make out is basically C2 and C3 is fused. And if you see this occipital atlas, which is better appreciated on a CT, this is just one second. Yeah. So this is C1 atlas, which is dislocated. In fact, what we can call it as a spondyloptosis, lying in front of C2 there and pushing the dens more into the foramen magnum, giving an acute cervicomedullary angle and compressing the cervicomedullary cord, as you can see it in midline cuts of the MRIs there. So these are all extreme cases, and these extreme cases, we call them irreducible only after giving a heavy traction, almost amounting to 1/3 of body weight under anesthesia on the operation day. We don't give any pre-op traction. But a majority of them, more than 90% of these congenital AEDs are usually turn out to be a fixed or irreducible AEDs. But the reason here is basically 2 or 3. Like as you can see, like one of the main reason is this longus scoli, which is attached onto the anterior arch and pulling the C1 down and keeping it there and pushing C2 more into retroversion. And this attenuated dome of C2 and the dislocated position gives rise to C1, C2 capsular contracture there. And these two important structures, the capsular contracture and the contracted longus scoli, let us see if we can release it through the transferal release in these extreme cases and get some mobility, and then we can allow for fixing there and use some maneuver to distract it anteriorly, and whether can we restore the normal anatomy. We had tried earlier, long back, only posterior manipulation, but The majority of them, even published by the other authors also, usually gives rise to a suboptimal reduction, very often what we call a spurious reduction. And this also gives rise to the suboptimal or incomplete neurological recovery because of the persistent tenting anteriorly of the cervicomedullary cord. And then in 2006, Wang's paper was published, as Professor Mihir also mentioned about him. And then we started this a transferal release for this fixed AEDs by our team, our mentor, Dr. Lahiri, Kshitij, myself. And I was able to carry forward this. We published this in European Spine, like about 15 cases. This we usually do it in the same sitting, but in two stages, the anterior and the posterior, where a lot of preoperative workup is also done, requires an ENT and a dental checkup, a good mouth opening, a good oral hygiene. We usually start with betadine gargle almost about 3 days prior and after each meal. Then study the angiogram there for like anomalies. And then on table, first in supine position, give a heavy traction almost amounting to 1/3 of the body weight, give a generous head high position, observe for 10 to 15 minutes. If it is reduced even partially, if it has come to a certain level, yes, then we consider it to be a reducible and then go ahead with only posterior there. But if it is not moving, then we label it as an irreducible and go ahead with a transferal release there. So we scrub the part with beta scrub, but the oral cavity scrub only with the Savlon solution, clinic with a saline. The next step, what we do is pass an infant feeding tube, take it out.
Dr. Ashok, your voice is not audible.
Dr. Ashok, I think some internet connectivity. I think your screen has frozen. Can you hear us, Dr. Ashok? Dr. Ashok, can you hear us? Okay, I think he is logged off. Yeah. We'll just wait for him to join, and in the meantime, can we have some inputs from Dr. Satish? Dr. Satish, so what is the role? Like you also showed a transoral approach in revision case, but do you have any indications where where your transoral approach or anterior release is required primarily before going posterior?
Dr. Satish.
Yeah, sir, can you take that question, Dr. Shrivastava, please?
So, in fact, all these discussion I was listening. See, anterior procedure is a very small procedure, and you have to just open and release the thing. You are not going to take out anything unless there is a bony mass and you plan to burr out. Otherwise, it is a soft tissue release, which is soft tissue which is so significantly contracted. The moment you put your knife or your cautery, it gives way. You get sudden feel of the giving way. It is so because patient is on traction. The moment you start releasing, it start getting reduced. And regarding this transoral surgery, we had a patient where there is a submucous oral fibrosis and his mouth opening was negligible. In that case, we started doing retropharyngeal as we do ACDF. We started doing using that approach. There was no need of any transoral. And even in Hans' place, people used to do tracheostomy and do the thing. So we started doing the ACDF approach, and you release the thing. It was so simple that after that case, I stopped doing any transoral. all these releases I started doing by the retropharyngeal approach. And see, if you go by the pathology, the tight structure is there, which is not allowing it to get reduced. So why not to address the pathology? Just release, add this small procedure. And most important in this CVJ is your getting the proper reduction. Proper reduction may be different for different people. My criteria is you have to have a normal clivus canal angle. If you have not achieved the normal clivus canal angle, it means you have not reduced it properly. Okay. Even in Goel's technique, I have seen some cases where the translation used to be there. It used to remain a little bit towards the foramen. Okay. So I think achieving the normal clivus canal angle should be the goal.
Thank you, sir. Dr. Ashok, is he able to connect? So can we just move on to the next talk? Kshitij, can we just play the next talk? I think once Dr. Ashok joins back, once his connection is restored, maybe we can get back to him. So the next talk is going to be on vertebral artery injuries, and I have sent a pre-recorded talk regarding that. So, yeah.
Hello, everyone. At the outset, I would like to thank the entire organizing team of BSS for giving me this opportunity to present. My topic is vertebral artery injury, and as it has been rightly told in the heading of my topic, it's a cause for panic. Vertebral artery injuries can be a catastrophic event and can be potentially life-threatening if it happens during the surgery. And the second part is all we need to know about it. And the most important thing that we want to know about it is the anatomy and how to prevent vertebral artery injuries. And a little bit I'll be also dealing about how to manage them if the unfortunate event happens. The vertebral artery has been divided into 4 segments from its origin. The vertebral artery at the CV junction is divided by Goel et al. Into 3 segments. So the V1 segment is one of the most important segments because it is between C3 and C2, and this is where the vertebral artery ascends from the C3 transverse foramina, and it varies to a significant extent in a supromedial curve in order to form what we call sometimes as the high riding vertebral artery. Once it exits from the C2 transverse foramina, the vertebral artery courses laterally as well as then anteromedially in order to enter the C1 transverse process. And this loop is slightly away from the C1-C2 joint, which helps us to do any intra-articular manipulation. And once it comes from the C1 transverse foramina, again, it courses posteromedially and then again anteromedially to enter the dura, which is again around 1.5 centimeters lateral to the midline. So as we know, vertebral arteries are one of the most, the variations and anomalies are quite predominant. It's around 2 to 3% in the normal population. 20% of patients in CV junction anomaly can have this, as well as 66% of patients with occipitalized C1 can have vertebral artery anomalies. Coming to vertebral artery anomalies in normal subjects, of course, there are several different ones which I'm not going to detail. Most of these usually entail one of the branches or the vertebral artery itself coursing below the C1 transverse arch, posterior arch, which obviously comes in the way of putting in a C1 lateral mass screw, and we should be very, very careful. The most common variation that happens is the hypoplastic vertebral artery, which often has been defined. There is no consensus, but it has been defined as a diameter of less than 2.2 millimeters. It's important to know which one is the dominant vertebral artery, which is the non-dominant vertebral artery, which is the hypoplastic or aplastic vertebral artery, which will help us decide and plan during the surgery. Of course, we should always be aware of what are the types of vertebral artery anomalies or variations that can happen in the setting of occipitalization. And even in this case, fortunately, most of these vertebral arteries actually enter one of the foramen, osseous foramen in the occipital bone itself, and they do not come in the way of the surgery at all. But we have to be careful about these type 1 and type 2, around 30-35% of the cases where the vertebral artery can go below the posterior arch of C1 and across the fused C1 lateral mass. And again, sometimes they can have a medial entry into the dura where we can, they are prone to injury while the dissection itself. I was already mentioning about high riding vertebral artery. Any internal height less than 2 millimeters or isthmus height less than 5 millimeters qualifies as an high riding vertebral artery, and there are several different classifications that have come in. This is one of the most accepted ones, where obviously on a rough note, if the vertebral artery cave crosses the half of the C2 pedicle, then it means that it can interfere, or the chances of vertebral artery injuries are higher while putting a C2 pedicle screw. Whereas as long as it is in the lateral half of the C2 pedicle, the chances of injury are higher. But of course, if vertebral artery injury happens, what is the next step? It can be, as I already mentioned, it can be a catastrophic iatrogenic complications. And there are several, even if we are able to manage these intraoperatively in some way, we are able to come out of it. There are several serious consequences that can happen. It includes fistula, pseudoaneurysms. And obviously, one of the most serious ones are cerebral ischemia, posterior fossa infarct, a pica infarct, or, even death if it involves the brainstem. So vertebral artery injury can happen at several different stages during exposure between occiput and C1. As I've told, if we dissect it too laterally on the superior margin of the C1 posterior arch, again, it can enter the vertebral artery groove. It should be very careful. It should not dissect more than 1.5 centimeters beyond the midline on the superior border of the C1 lateral mass. Further dissection, if it is required, it has to be on the inferior margin of the C1 arch in order to reach the C1-C2 joint. And the second point where we can actually injure is where it exits from the C2 transverse foramina, where again too much dissection superolaterally can cause, especially if you are using a monopolar, can cause injury to the vertebral artery. Again, it's important here to go to the inferior margin of the lateral border of the C2 lateral mass, as well as, and then go superomedially tracing the pars in order to identify the trajectory of the screw that is required. During screw insertion also, the vertebral artery can get injured. Obviously, this happens deeper inside the bone, which will not be visualized superficially. This should be avoided, ideally should be avoided with appropriate preoperative evaluation, choosing which is the correct type of screw in that particular case to be used. And of course, in borderline cases, using a 3D navigation like as shown here can help significantly in reducing the incidence of vertebral artery injuries. Obviously, the treatment goals of vertebral artery injury are to achieve control of the hemorrhage. Obviously, the first and the primary objective once the bleeding is there. At the same time, as much as possible, and it's very utmost important, to prevent acute central nervous ischemia and prevent postoperative complications such as embolism and pseudoaneurysms. And this can be achieved in 3 different ways. One is primary repair. The second one is a bypass, the vertebral artery bypass, an extradural to intradural bypass surgery, or in some cases, whenever it is not possible or it's not going to cause any significant consequence, sacrifice the vertebral artery. The general measures, as has been rightly told, we should not panic. We should send for a vascular surgeon, communicate with our anesthesia team, advise, arrange for adequate blood products, ensure that the head is in neutral position so that the contralateral vertebral artery, which is not injured, is not compressed due to the rotation of the head. Of course, digital pressure, large pieces of hemostatic agents, and cottonoids can be used in order to pack and achieve hemostasis and define what is the area of injury, whether any proximal and distal control can be achieved immediately, or whether any temporary clip can be placed in order to achieve significant control of the bleeding intraoperatively. So this is just a brief flow chart which shows how to manage intraoperative vertebral artery injury during exposure. Obviously, it is important in any case to determine whether it's the dominant vertebral artery or the non-dominant or a co-dominant vertebral artery. And the second point is whether any proximal and distal control of the vertebral artery segment is achievable. If it is a non-dominant or a co-dominant vertebral artery, and with a good retrograde flow, we can always sacrifice or tamponate that particular artery. If there is no retrograde flow, or if the injury has happened in a dominant vertebral artery, and if primary repair is possible, it should always be attempted. If primary repair is not possible, we should achieve control of the hemorrhage and immediately come out. Immediately an endovascular repair or a bypass has to be planned to prevent any further kind of cerebral ischemia. If it happens during screw insertion, again, the same question we need to answer, whether it's a dominant or a non-dominant. Obviously, the issue arises if it is a dominant vertebral artery. We have to change the trajectory and we have to put an alternate screw if possible. And we have to use a bone wax to control that bleeding that is there. Is usually pretty much easy to control bleeding if it has happened within the, while inserting the screw or while doing the tapping. We should always do in these cases post-op angiogram to see what is the nature of injury, whether it's a complete block, whether there is a pseudoaneurysm that is formed, and of course we should plan for an endovascular repair or a bypass as has been planned. Even if it is a non-dominant or a co-dominant vertebral artery, And if it is a, if we are able to achieve tamponade and, hemostatic agents, and we are able to put the screw in the same trajectory, we should always do a post-operative angiogram, to rule out any kind of a pseudoaneurysm. Sometimes intimal injury can cause thrombosis, and this thrombus can embolize, into the intracranial, and cause significant, embolic infarcts in the posterior fossa. So there are general post-operative measures that we should take care. We should always have close post-operative monitoring, look for lateralizing signs as has been listed over there. Antiplatelet therapy is very, very important, as has been shown that if it is not started, if there is a 10-fold higher risk of thromboembolic events post-operative, post-vertebral artery injury. We should restrict neck movements, of course, BSA, as I already mentioned. To conclude, there are several different things that we should that we should take care while treating vertebral artery. There are 4 A's. We should know the anatomy in detail. We should assess the pathoanatomy whenever we are doing a surgery. Of course, during exposure and during screw placement, we should avoid vertebral artery injuries. And if it happens, I've already discussed what is the action that needs to be taken. Thank you. Thank you for your attention.
Dr. Ashok is back. Dr. Ashok, could you put? Yeah. So can you just continue? Please continue your talk if there are no issues at your hand. Please continue the talk. Dr. Ashok, can you unmute yourself?
Yeah, can you hear me now?
Yes, now I can hear you. Please continue.
Okay, I think I think it was here somewhere.
Yes.
Yeah. Okay, so once we decide this is irreducible and we go ahead with a transferal release there, so we scrub the part, we scrub the oral cavity with Savlon and saline. And the first thing what we do is we pass an infant feeding tube. Through the nose, take it out through the oral cavity. We suture the uvula to the infant feeding tube, and then we pull it out. So our uvula gets retracted. We we drape the parts. This is the head end. And as you can see, this catheter is basically that uvula pulling out this thread, and that's the mouth gag. We take a vertical incision after infiltration there. And if this is the bony alignment, this is how the incision goes, and there's the bony anatomy. This is where the longus scoli is there. We not only incise it, we excise a part of the longus scoli, both the longus scoli, and then we go ahead and incise the C1C2 joint capsule. As you can see here, that's the tight longus scoli. We excise a part of the longus scoli both sides, and then we incise the C1C2 capsule till the lateral border there. And then we use periosteum elevator into the C1C2 joints on both the sides. We distract it upper niche. Yeah, we use a blunt pukas. We use it like on horizontal and a vertical manner to even distract it further. And the amount of mobility we get it, as you can see it here. The last option picture is while pressing it from the posterior aspect. Like as you can see it, at the moment I'm pressing it from the cetospinous process. So we are creating a fixed AAD into, in fact, the hypermobile AAD. The steps which I follow is that we always cut the longus scoli from the C1 posterior arch. We cut the C1C2 capsule till the lateral border, enter C1C2 joints and mobilize them with the help of pukas and periosteum elevator. After these 2 compulsory steps, yes, if we still feel the release appears to be inadequate, then we go ahead with excision of the arch of the atlas. This will allow the dents to come forward when we manipulate it from behind there. And then we suture it, suture the posterior pharyngeal wall mucosa with a 3-0 Vicryl. The throat is packed with diluted and soaked saline betadine gauze there. We very carefully turn this patient because now these patients have become like an hypermobile AAD. we usually use, like as we were discussing with Professor Abumi, we use an under-contoured rod or an under-contoured plate, like a cobra hood molding. And when you press this onto the occiput, like you can see here, like in the first picture, there is still some residual atlantoaxial subluxation. But when you press it onto the occiput, we get an absolutely sub-basin reduction, as you can see it on these CT scans, and a beautiful funnel-shaped cervicomedullary canal. These are extreme cases. And then we do a bone grafting, as like already been discussed often. So besides these 15 cases which we reported in the European Spine Journal, we added almost another 15 cases, total around 29, 30 cases. And these are all extreme aid is what we were talking about till now. And the advantage of this is that these are absolutely very short procedure, hardly lasting for about from 20 to 40 minutes. Then with almost a negligible blood loss, hardly 10, 15 cc's. And it's a direct approach, releasing those tightened structures rather than manipulating all from behind and trying to get all these maneuvers there. I think little adding this small step of anterior transferal release in this irreducible type, we can achieve an excellent mobility. Excellent to the sense, this fixed AEDs almost becomes like an hypermobile AEDs. Thank you.
Thank you so much, Dr. Ashok, and thank you for joining back in. I think there was a brief interruption due to probably some network issue. So, are there any questions for the anterior release? Any comments or questions? So if there are nothing, then we will proceed to the next talk. I think Dr. Arjun is ready with his next talk. I would invite Dr. Arjun Dhavle to present his talk. He's going to be talking on special considerations for pediatric CV junction fixation. Dr. Arjun, over to you. You can please start. Yes, you shared your screen. We can see your screen. Please proceed.
So thank you very much for this invitation. And I'm going to be talking about pediatric CVJ. So this is a 3-year-old child with Down syndrome. And you can see that there is atlantoaxial instability. So the question really is, how do you manage it? What are the diagnostic challenges? What are the surgical challenges? What are going to be the results and what can be the complications here? So I wanted to define this, and really these are the questions. And we've looked at this in children below 5 years, and it's actually more difficult in younger children than in adults. There is little literature on this, in smaller children. And of course, you need the IONM and good pediatric anesthesia. And also you have to have a good variety of implants available. So basically, there are issues with understanding, because the child is small, so it's very difficult to get a history. Getting MRIs, etc., requires sedation. There are often syndromic associations here. So this is a 1-year-old, 9-month child with Morquio syndrome with difficulty in walking, hypertonia, grade 3, hyperreflexia, and exaggerated reflexes. And we had to have X-rays, a dynamic MRI, You can see on the X-ray the issue which is here. And that's the MRI showing on flexion that there is an increase in the instability and the compression. And this has been looked at, in syndromic children, looking at basically at flexion extension MRI. Surgical challenges here are the exposure. In small children, of course, you have to do a little lesser exposure than what you do in adults. The incidence of anomalous vertebral arteries is more common. And then the fixation anchors, which are more difficult. VA injuries can happen. They can happen during the exposure here or during instrumentation. And it's also important to maintain meticulous hemostasis, because this is a small child and the blood loss cannot be as much as would be permitted, an adult. So you have to really have a watch on how much blood you're losing. So we wanted to look at the results in smaller children below 5 years, especially. And, we did preoperative planning with this MPR CT and the HOROS. This study has been published, with Kshitij, me and Dr. Nene. We looked at this in 25 children. And it's basically the use of the free software with the use. Now, basically, there are the images which you can just see on the CT. And then there is the PACS, which allows you to kind of look at it. But the non-orthogonal reconstructional is actually what is most important when you're planning your trajectories. And that is, definitely advisable in small children because you won't get a second chance. Also, you're looking at the volume rendering, looking at the DICOM data and looking at the pathoanatomy and the fixation anchor planning. So there's a child who, with a syndrome who had lysis of C2. And you can see that lysis of C2 and then basically had to be fixed with hooks because there was no other alternative. So what are the types of surgeries you can do? You can do a C1, C2 transarticular surgery. You can do lateral mass, pedicle screws, laminar screws. And you can do occipitocervical fusion. And you need to have the anchors available. Marcelin tape is an important thing to keep available if you can't get the screws. And you have to be careful about the hooks. So now union is something that is important, especially in smaller kids. The neurological recovery, what's happening? Are the children improving? And what are the complications you can encounter? Non-union implant failure, neurological worsening. So when we looked at, this, we found that we had a larger number of congenital and syndromic patients. And many of them underwent occipitocervical fixation. So these are the results. We had implant failures, non-unions, neurological worsening. And in some cases, fixation below C3 was also required. This is a 4-year-old child with Down syndrome, non-walker, okay, and actually had a flexion extension X-ray. During the flexion X-ray, the radiologist technician actually hyperflexed. You can see the deterioration which happened after that. This is the child's MRI showing the C1, C2 instability. That's the preoperative planning of the trajectories, and that's the fixation, transarticular screws. And this patient basically had a good 5-year follow-up. This is the child at 5 years. So this is another child, 4-year-old child with Morquio syndrome with difficulty walking since 6 months. Grade 3 power, and again a transarticular screw fixation was done. However, this child started to have a loosening of the screw, on one side. Child was still able to stand, neurologically improved. And with that 2 years, you can see that one of the screws actually has inferiorly migrated. There is a suboptimal reduction, but the child is still ambulatory. So we are observing, but it is likely that this child may require revision. There's another patient, a little older patient with a dysplasia, who had a C1, C2 instability. Here again, there is a very anomalous vertebral artery. You can see there's no trajectory for a pedicle screw on the left. And here again, then a laminar screw was used. That's the fixation. There's another child, very small, 1 year and 8 months, where it was not possible to get a suitable bony fixation. So only Marcelin tape was used distally. However, this patient required revision later, and distal extension. And you can see that is the Atlas cable which is used. This is a 5-year-old child with atlantoaxial instability who had a unilateral fixation, but then had a fall and had a worsening postoperatively. That's the MRI. This patient had to have a OC fixation along with C2 laminar and C2 power screw. And that's the follow-up. So sometimes, you can have rare syndrome. So like this was a child who actually presented to us with a posterior circulation stroke and had a undiagnosed dysplasia. And we actually had to wait after the stroke and then do a fixation. We had to avoid here a pedicle screw because there was already a vertebral artery stretch. So that was a preoperative planning, and then the fixation with a laminar screw on one side. And this is a patient where patient had operated, and then there was a loss of reduction, and subsequently then me and Kshitij revised this case, and we did what Dr. Rathod just described. So we removed the screws and the plate at the back first, then we flipped the patient again, and anteriorly we did a transoral release, and then we did a posterior fixation, and that's the outcome. So take home message: you have to have a high index of suspicion. CBJ junction amonology children are more difficult to treat, and you have to have alternative fixation. And but it is to be done when it needs to be done, and you just have to do it appropriately. Thank you very much.
Thank you so much, Dr. Arjun, for showing those complex as well as challenging cases. What is the youngest age? What would you would recommend that probably a transarticular screw or any kind of a screw-based construct can be used in the pediatric age group? That is number one. Number two is there any special type of screw that you use, or it's our regular 3.5 mm diameter screw? So can you just shed some light on these two questions?
So the 3.5 is a good screw. There are some of the companies have now come up with the 3 mm screws, which are good sometimes for the smaller laminae, etc. The decision is taken on a case-to-case basis. It is based on the preoperative planning, and basically what trajectory is going to be allowed, what is the fixation that is going to be permitted in that patient. And of course, if you just can't do anything else, then you have to have that Atlas cable, and that is a sort of bailout option.
Great. So any comments or any questions from other faculty? Yeah, Dr. Ashok, please.
Yeah, especially those children who are less than 3 years, even the isthmus diameter is hardly, sometimes even 2.7 mm screws are difficult to accommodate there. Last few cases I have done only K wiring technique, used even a threaded K wires, but and to prevent it from migrating proximally or migrating behind, pulling out, then what I do is bend the wire and use a C2 wiring around the wire, so it doesn't migrate. Like if you allow me, I can just show this, so that, like I say, we don't have to put a screw. I mean, can I share the screen if you want?
I think we'll have one more talk left, probably. Because we're already running.
Sure.
We would love to see that. It's very interesting, but because we are already running out of time, we are already running late. So let's go on with the next talk. If there are no further comments or questions. So the last one, it was supposed to be a little earlier. We were waiting for Dr. Bharat Dave to join us. He is busy and he's on the podium in another session elsewhere. So we'll just run his talk on atlantoaxial spacer insertion. So it's a recorded talk by Dr. Bharat Dave.
Spacers are used for the vertical reduction and basilar illumination, and it allows the C1, C2 reduction with minimal or no inflection.
Can you hear his voice?
It's very mild. Can we increase the volume?
Okay. Volume is max on my end.
Is routinely cut. Very nicely described this procedure by our own Dr. Sarath Chandra, who is also faculty in this seminar as well. He has described very well the single stage posterior only technique to reduce basilar illumination, distraction, compression, extension, and reduction. He has developed his own device that helps to reduce and get the reduction very well. Midline subperineal dissection is done. Exposure from oxygen to C4, and we should have the joint exposure. Ideal would be to have the non-stick bipolar cautery, and it is useful to prevent the bleeding and dissect it rapidly. This is demonstrated very well in this video. Let's see the product when it has to be done. Something like this, sequence of paper. Points of venous bleed, epivenous bleed, plexus is medially. I think we really have to have it clearly seen, visible, and we should really have the whole venous plexus coagulated, and we should go from medial to lateral. Coagulation with anastomosis will be done as mentioned with the non-stick forceps, bipolar forceps. If it bleeds, then we may have to put the patty and gel, wait for a few minutes. If it continues to bleed, then probably one really need to have the head up, blood pressure around 70 mean. That also helps in reducing the bleeding as well. So in the fact, this bleeding is something which we really have to control it well, and that is the key to access to the C1C2 joint. C1C2 joint can be accessed by following the superior border of the C2 ligament, and we will directly end into the joint. C2 ganglion will be seen as shown in the lower figure. Preserve if one can, or cut it with the pottery and leave the stump so away from the neural side as much as one can, because otherwise you need to see a circle. Once the joint is exposed, then one can put the small osteotope and one can open it up. And one really need to burn the end plates of the C1C2 joint in order to put the cage with the bone duct and the fusion. That is very important. We have the overall navigation, and it increases the accuracy, and honestly it has changed our practice, and it also allows us to put the screw in the non-traditional way. So the entry of the screw could be different, and many times these cases have scoliosis as well. So not the classic entry which is normally described in the textbooks or one has experienced. We have found n number of times that the entry can be different variable, particularly the angle, right, left angle, and mediolateral cranial caudal angle, and mediolateral angle can be different as well. And as I mentioned, we have 3 sets of the warm navigation that helps us in putting the things together. And also we have the 4K 3D exoscope as well. That also helps us in visualizing it better. And it was a fixed AAD, Atlanto axial dislocation, as you can see. That it was pretty nerve-wracking case. And it was also having the occipital odontoid right into the pulse. And we managed to reduce it with the careful dissection, and we were putting the spacer in. And we usually drill with the diamond bar in order to stop the skiing. And that also we use it with the navigation as well. So once that is done with the C1, C2, one can remove the C1 screw and then put this person. That also helps us as well. And then afterwards, one need to just quickly drive the screw in and then stabilize. And as you can see in this case, we had in the cages and then we had to the pedicle screw. And this is the here follow-up of the same patient with the side of the body.
So that is it.
Yeah.
I don't know if you could hear, the voice was very low in this presentation.
Yeah, and there was a lot of disturbance as well. So, anyways, I think that brings us to the end of this session, and I should say that it was very exciting, very wonderful, and there was a lot of discussion about the topics that we were, that we have encountered in this particular session. Any closing remarks from the senior faculty, Professor Sharath or Dr. Shrivastava? Anything that you want to add or comment at the end, and before we say goodbyes?
It was a very wonderful session, and we were expecting that all these cases, all these topics will be discussed in length, and I think that is the reason we got little bit delayed. But I think we have nicely utilized the time, and I would request if Dr. Sarachan wants to make some comment. He's around.
His video is switched off. So, hello. I'll just in the meantime address all the delegates. Don't be afraid. Some part of this discussion was maybe everybody is at a different level when they are doing craniovertebral surgery. So some of you maybe doing something, want to learn something basic versus the end session was quite complicated, and even for experienced surgeons, I have, like myself, I find some of these techniques quite challenging to do. But it's a stepwise process, so don't get disheartened. We have a lot of time coming up to the cadaver course. Utilize the classroom to the best of your ability, and we are there available to answer your questions. We'll put up cases on the classroom, and we'll discuss. At least there'll be something for everyone among the 20 of you here. Just don't feel shy. You can ask us anything. There is a WhatsApp group also for you to ask, and on the day of the cadaver, at least we want some basic objectives to be achieved. You should be at least confident enough in inserting screws in normal anatomy, which the cadavers will be, like putting in the C1 screw, C2 screw, and the occiput screw, and understand the basic principles. Like some of the principles were laid out in this course. Like for example, Dr. Sarath Chandra said, never fix something without a good reduction. And so that's so important takeaway, and a very clear statement that you should take home. Those kind of pearls of wisdom you are going to get in sessions like these. So remember those. And I think we'll meet again in person on the 21st. In the meantime, we can keep the interaction online, either on the WhatsApp group or on the Google Classroom. And please tell us how we can help you. Give us a feedback, and then we'll address all that. We have some time before we meet you in person.
And also tell that we will share the Google Map link, the venue of the workshop. It is between Sion and Chembur, and you'll be getting that address information on WhatsApp.
All right. And we'll summarize all these talks for you on the Google Classroom, and also there'll be a recorded session. This recorded session will be available for you to watch. Even if you don't get time before the conference, you can watch it afterwards also. But just at least the basic ones, at least revise them before you come for the cadaver course. With that, I think we'll end this session.
I thank faculties and all the delegates for making this session wonderful. The faculty has taken out their valuable time and made it very informative. I personally thank all of you. Thanks a lot, and I welcome
Thank you, sir.
organizing team, and you please do join us from 18th onward. So 18th is the first day of ACCon 2024. All of you are most welcome. Thank you. Thank you very much. I thank all
Thank
my
you.
moderators, my co-chair, Dr. Kshitij, Dr. Satish, Dr. Mihir, Dr. Umesh, Dr. Manish. Thanks a lot.
Thank you, sir.